Welcome, everybody. Welcome to the second Rhoton Society virtual meeting and the 8th International Symposium in Microneurosurgical Anatomy. Today, we're going to celebrate Professor Rhoton's life and legacy. He is the master and mentor of several generations of neurosurgeons. The Rhoton Society came up as an idea from several Rhoton fellows that we joined sometime after Professor Rhoton's death when he passed away, because we wanted to carry on his legacy and continue expanding the knowledge of surgical anatomy into the field of neurosurgery. There is a precedent of this society, which is the International Symposium on Microsurgical Neuroanatomy, which was first hosted in Japan in 2002 and by Dr. Matsushima, who organized it. And there have been 6 of these symposiums, 4 of them in Turkey and 1 of them in Brazil, hosted by Professor Evandro de Oliveira. 2 years ago, we celebrated the first Rhoton Society meeting in Tianjin, China, organized by Dr. Tong, and it was the 7th International Symposium. That was a very successful meeting with a spectacular faculty and numerous attendees. And as we were told by Dr. Tong, a meeting with a very deep influence in Chinese neurosurgery, following Dr. Rhoton's goal. People would say, why another society? This pretends to be just a small society, a society for the study of microsurgical neuroanatomy and technique, with 3 main goals. One is to make neurosurgical operations more gentle, accurate, and safe through the knowledge of anatomy, as Professor Rhoton taught us. 2, to facilitate anatomical research that will improve our understanding and surgical approaches. And 3, to ensure that this field is embraced by the next generation of neurosurgeons. And these are the goals of this meeting. As you will see, we will have many masters of neurosurgery showing how to do accurate, gentle, and safe surgery. But we'll also have younger fellows that are doing new anatomical research aiming to improve and expand our field. And we truly hope that with this meeting, the next generation is heavily influenced. The tradition of working in the lab and spending time to learn anatomy and techniques has been carried by giants and pioneers in our field, like Professor Jasahil and Evandro de Oliveira and Professor Rhoton. As Dr. Rhoton used to say, we want to go to the lab to do perfect anatomical dissections, simply because we want to do as perfect as possible surgical operations. We want to develop Rhoton's X-ray through vision. The best image guidance is the knowledge of microsurgical anatomy. We want to translate from the lab to the OR, as Professor Evandro Oliveira showed us many times with his mastery. And we want to continue following Dr. Rhoton's example with his teachings, showing the next generation of surgeons anatomy and techniques with the same enthusiasm that he always had. This meeting is hosted in the Bay Area, San Francisco Bay Area, where Stanford University is located, an area of great tradition and innovation. And this is the theme of our meeting, tradition and innovation. I want to acknowledge the companies that have supported this meeting. These companies provide us with technical innovations that are key for our daily work, but also they are key in supporting our educational activities. These are KLS Martin, Medtronic, Mizuho America, Mutuo America, Stryker, Stores, and Spyway. And I would also like to thank our CME office for the great work for US-based physicians. Remember, this is an event that you can claim credits for. I would also like to thank the support of our Stanford Neurosurgery. Dr. Gary Steinberg has been our chairman for 24 years, and you will hear from him later in innovation of cerebrovascular surgery. And we're excited to welcome Mike Lim as he will help us take the department to a new level. I would also like to acknowledge Jenny Visitacion, my admin assistant, who has done a phenomenal work putting all this together with us. And of course, my esteemed colleagues and friends from the Rhoton Society board meeting. All of them have had an enormous role in developing this. Among all of them, I want to highlight Professor Evandro de Oliveira, master, mentor, hero. He represents the supreme art of microneurosurgery. Tomorrow, we will have a very special session dedicated to him. Dr. Wen will be leading this session about his mastery, his legacy, and his philosophy. We will also have Dr. Martins, Carolina Martins, along with Dr. Sorenson, who developed the Rhoton collection, as many of you know, and they will be sharing with us very important knowledge on how to work in the lab, teamwork, and newest techniques for laboratory research. For those of you interested in developing a lab or improving your lab, this will be a very useful session. To start this session, we'll have a very special guest, which is Alice Rhoton, Alice Blasak-Rhoton. She is the oldest daughter of Professor Rhoton, Dr. Alice Rhoton, and she will share with us the great values that Dr. Rhoton also taught us, the family values. He treated all of us as family, even like children, and she will share this very important facet of Professor Rhoton. We have the very important presence of the Japanese Rhoton School, that, as you know, is the most numerous number of fellows from Dr. Rhoton, and some other masters of microneurosurgery from the Japanese neurosurgery. And we are honored to have them, all of us, joining us. Today, this afternoon, we have these truly spectacular surgeons, cerebrovascular samurais, sharing their expertise, also in topics related to skull-based surgery and brain surgery. It's been such a privilege to work with Dr. Morcos. I thank him very much for his support to the society and to put together this program and this meeting. Himself, along with Dr. Rubino, my dear friend, had made a great session on cerebrovascular skull-based surgery. This will happen next weekend. Professor Tong, who some of you know, is a key person in China because he helped spreading Dr. Rhoton's labs across China and deeply influences his peers over there. He will be showing us tomorrow in a spectacular session on bypass with two giants in our field, Dr. Mike Lawton and Baskaya, some of the most demanding and difficult operations such as bypass surgery. And I'm very excited to hear this lecture from Dr. Tanikawa on his mentor, because a lot of this meeting is about mentorship. Kamiyama's instruments and surgeries. I think it will be a spectacular topic too. Similarly, we'll have tomorrow night a very exciting session on white matter anatomy and complex brain surgery with Dr. Turi as our special guest. And I've always been an admirer of his tremendous work in the field, carrying with Professor Jahil's legacy, the impact of white matter dissection in complex brain surgery. And we'll also have these other two ANs, Dr. Aaron Cohen-Gadol, who you all know because of his role in developing the Neurosurgical Atlas, with a great resource for all of us, along with Dr. Goel, a genius in skull-based surgery from India. And of course, we'll have a couple of sessions on skull-based surgery and endonasal endoscopic surgery with my dear friend, Professor Dr. Garner from University of Pittsburgh, where we work together. And this will be tomorrow. We'll talk about endonasal versus open approaches, when to choose one or the other. And we'll end up the meeting sharing with Dr. Goto, a leading skull-based surgeon in Japan, what are the limits and how would they push them for endoscopic endonasal surgery. I would say, to finalize, that not in my wildest dreams, I would have hoped to share with all of you guys in the board meeting. Such a privilege to work with you. I thank you very much, and I give you now the voice. Please, Jacques, we want to hear from you.
Thank you, Juan, for this beautiful introduction to this phenomenal meeting that you have put together, and our collective thanks go to you. Before I say my very brief word, I am delighted. I hear that Evandro de Oliveira is with us watching this. Evandro, if you're hearing me, I give you the warmest virtual hug I can give you and your beautiful family. We always think about you. We're here. In 2016, in February, I had just become the president of the North American Skull-Based Society, barely a week, and the news of Dr. Rhoton's death came to me and to all of us. And it was just unbelievably painful news to get. And to the young people, perhaps, who are joining us today, perhaps who've never met Dr. Rhoton in person, I'd like to read the last paragraph of my eulogy that I wrote within a few days of his death. Dear Al, if heaven exists, we know you made it there and have already started feverishly rearranging and reclassifying its anatomy to the dismay of all its angels. You may have left us, but we will never have to remember you, for remembrance implies forgetting at first. How can we forget you? Like the fabric of space-time that engulfs us, you created for us the fabric of neuroanatomy and the tools to operate on it in that gentle, delicate, accurate way. Like a true messiah of sorts, you revealed hidden truth to us. Your prodigious intellect has bequeathed thousands of images and notes for posterity. The entire medical community will spend the coming years celebrating and benefiting from your achievements. The NASBS will honor you and celebrate you in our upcoming 2017 annual meeting, which we did, of course. Your boyhood dreams have been realized multiple folds, but you have failed, if it can be called a failure, in one regard, and that is simply because of your unique humility. You thought that all you were teaching us all these years were anatomical maps and facts and techniques, a window to your mind. Little could you suspect in your self-effacing demeanor that your even greater contribution for generations to come is to have enriched our hearts too by allowing us, unknowingly, a window of exposure into one of the greatest medical souls that have ever lived. And Dr. Rhoton, we will never forget you, as this meeting is indeed an example of that. Thank you.
Beautiful, Jax. That's beautiful. Carolina, please.
Sure, Juan. I would like first to greet all the panelists, all my friend panelists, and to say to you, Juan, that Dr. Rhoton would say, and you know these words very much, that this is a world-class program. So congratulations on your program. And then let me greet everyone in Portuguese. Boa noite a todos os lusófonos e sejam muito bem-vindos à Rhoton Society. Essa é uma sociedade acolhedora que só deseja de vocês duas coisas: interesse em anatomia microcirúrgica e a capacidade de se unir para construir, não para subtrair. Para o professor Evandro, que está nos ouvindo, mestre, seja bem-vindo. Grande programa e nos vemos em breve. Obrigada. Thank you all.
Thanks, Carolina. Pablo, do you want to address? Pablo, you're muted.
Okay. Hello. Thank you, Juan, for the opportunity, and congratulations for the tremendous scientific program. I will give the welcome in Spanish for the Spanish people. So, por ende, bienvenidos a todos los hispanoparlantes a este meeting. La verdad que es un gran esfuerzo, sobre todo realizado por el comité, especialmente por mi amigo Juan, que realmente ha convocado a grandes cirujanos que casualmente, y no por casualidad, sino por causalidad, son grandes anatomistas también, no solo cirujanos, sino anatomistas de todo el mundo, así que esperemos que toda la información, siguiendo el legado del profesor Rhoton, sea muy provechosa para todos, y bueno, que sea un excelente congreso. Bienvenidos a todos.
Bravo, Pablo, bravo. Professor Ture, would you like to address the audience?
Of course. First of all, I congratulate you for such a great meeting. In this COVID pandemic crazy period, this is now historical moment for Rhoton Society also. I congratulate you, bring together from many people from all over the world. Günaydın değerli meslektaşlarım, arkadaşlarım. Böyle bir toplantıda bulunmak hepimiz için büyük bir şeref. Profesör Rhoton şüphesiz ki hepimizin meslek hayatında en önemli rolü oynayan, bizim gelişmemize en büyük katkıda bulunan birkaç hocamızdan biridir. Kendisini rahmetle anıyorum. Işıklar içinde uyusun, toprağı bol olsun ve bize bıraktığı bu meşaleyi hepimiz en iyi şekilde değerlendirip daha ileriye, daha güzele doğru iletmeye çalışacağız. Bu arada bu fırsatta hocam Profesör De Oliveira'ya da saygılarımı iletmek isterim. Çok teşekkürler. Thank you.
Thanks, Dr. Ture. That's fantastic. Can we please have Dr. Abe address our Japanese audience?
Okay, thank you very much, Fang. It was such a great meeting. And let me introduce in Japanese. So, 日本の皆さん、おはようございます。この会は2年前に中国で第1回がされまして、本会がスタンフォード大学のファン・カルロス・フェルナンデス・ミランダ教授が、作ってもらいました。小林先生、日本からは小林先生、松島先生が中心で、この会を運営していただきまして、非常に素晴らしいプログラムになっております。今週末、来週末と、フリーで見られますんで、皆さんどうぞお楽しみください。Okay, thank you very much.
Thank you very much. I think that's wonderful. I think with this, we can finish our first part of the meeting, and we're going to go with Dr. Kobayashi for his presidential address. Please, sigue.
Thank you, Professor Miranda. It's a great honor for me to speak to you today. And this topic's history of microneurosurgical anatomy. Now, two contents I have listed here. The first, I would like to briefly talk about Dr. Rhoton and the Rhoton Society. Now, Dr. Rhoton for me is these characteristic terms. I can characterize him as anatomist, neurosurgeon, inventor, educator, and humanist. Now, as microneurosurgical anatomist, he published more than 500 publications, including anatomical original article genome. Textbook Rhoton is very famous, compiling his 50 years work. Originally, of course, in English, then translated into Chinese, Portuguese in Brazil, and in Japanese 2 years ago. Now, Dr. Rhoton graduated from Washington University, studied his residency at Columbia University, finishing it at Washington University and Barnes Hospital. And Professor Schultz, it's interesting to tell you that Dr. Schultz was an instructor of anatomy at Harvard Medical School before he came to St. Louis. He was the editor of Journal of Neurosurgery. Now, when he came to Mayo Clinic in 1966, he was a neurosurgeon, but he worked in a laboratory in collaboration with the professor of anatomy, Dr. Hollinshed. And then he left Mayo Clinic 1972 to University of Florida to president chair neurosurgery. I had a chance to work with Dr. Rhoton for 6 years at Mayo Clinic. And Dr. Rhoton, neurosurgeon. At Mayo Clinic, he was a staff neurosurgeon for 6 years at the University of Florida. He was a professor of surgery and neurosurgery, worked for 44 years, particularly acoustic tumor, meningioma, aneurysm, microvascular decompression, and so forth. Now, Dr. Rhoton was very much interested in instrument inventor. Why? According to my friend Arthur Day, he was the first resident to Dr. Rhoton at University of Florida. He emphasized Dr. Rhoton's clinical experience and his inventive mind. And Dr. Rhoton served as the president of the Third International Society for Neurosurgical Instrument Inventors, held in Las Vegas in 1999. This meeting was organized by Dr. Sugita and myself in Nagoya 1995. And several ISNTI meetings were held in various places in the world. Second meeting was held in Berlin, organized by Mario Brock, Professor Mario Brock. You see many distinct neurosurgeons were invited to guest speakers. Now, Educator. He established cadaver dissection laboratory in 1975 for research and education. Cadaver dissection courses and seminars numerous times in the United States and all over the world. Published, as I said, many original papers on anatomy, and treated as Rhoton, very, very famous and widely read. Dr. Rhoton's collection in an archive of his materials sponsored by WNS and the foundation. He was really a distinguished teacher. You know, nobody disagrees with him being great humanist. I like this word, humble and humanistic. Now, anatomy education in Japan, Dr. Rhoton's contribution to Japanese neurosurgery started in 1986, meeting organized by Professor Kitamura at that time in Fukuoka, Japan. Dr. Rhoton was honorary guest. And since then, we have organized 33 annual seminars with the average attendance 700. We have published proceedings each time as many as 20 volumes. During this time, we are thinking about an idea, why not? We are having an international such meeting. Here it is 2002. At the time of Japan Neurosurgical Society a meeting in Matsumoto City, Japan, we invited Professor Rhoton as an honored guest. And of course, we had a cadaver dissection course. At the same time, we organized the first international symposium on microneurosurgical anatomy at a satellite meeting with Dr. Matsushima president and Dr. Rhoton as honorary president. This lasted many years until now. After Dr. Rhoton passed, we have this meeting was called also as Rhoton Society meeting, and this was organized as Dr. Miranda said in China in 2018. And the second Rhoton Society meeting is now being opened in Stanford, organized by Dr. Miranda. Now this is a photo I shown before, taken at that time. Names are Rhoton Society board members. Now current officers of the Rhoton Society members are composed of former Rhoton fellows and neurosurgeons who are interested in anatomy are welcome to join this society. Evolution of microneurosurgical anatomy, this is the main topics today for me to speak. Now, before that, what is microneurosurgical anatomy? In my mind, it is topographic anatomy, fusing images of neural structure of the brain. It is roadmap for conducting an accurate and safe microneurosurgery. And it is to understand various approaches, to review them, and to help create new approaches. First, history of anatomy. This is a scheme I'm going to show you repeatedly in the following presentation. Historical overview of anatomy and surgery, anatomy, history of surgery, history of surgical anatomy, and history of microsurgery. Now, anatomy in ancient times, as you know, Hippocrates, father of medicine, his anatomical knowledge from injured human dealing with rather superficial part of the body. Now, first human anatomy dissection was performed by Herphilos, Tokyo Herphili. And Galen came on in Roman time from Pergamon. His anatomy was based on monkey anatomy, of course, monkey anatomy, and his knowledge remained uncontested until Vesalius came along, Renaissance time. He wrote Anatomy Procedures, a book, and he was called Father of Anatomy. Now, it is interesting to know, I like to stress this, anatomy started not for surgical purposes, but as a field for scientific pursuit. Now, anatomy and Renaissance period and thereafter, there are a couple of names I have to mention. One is Mondino. He revived the cadaver dissection after the Middle Ages and wrote first modern anatomy textbook. Andreas Versalis, Padua, Italy, originally from Belgium, published anatomy textbook, very famous textbook, Fabrica, with thousands of illustration. And his anatomy was the Galen's Anatomy Plus, human anatomy from his dissection of human cadavers. And he is called father of modern anatomy. Now, at the time of Vesalius, surgery started to begin, modern surgery, I mean. Paré, he was a barber surgeon, turned army surgeon. He was called father of surgery. He wrote textbook in French, not in Latin, which popularized the anatomy and surgery over entire Europe. Now, in 17th and 18th centuries, surgical development was rather slow because of lack of anesthesia and antiseptic environment, but it did develop, and anatomy itself developed very much with the new knowledge such as by William Harvey, circulatory theory, Thomas Willis about anatomy of the brain. And these knowledge were introduced in addition to all the anatomy knowledge by surgeon anatomists such as Dionis and Cheselden, England. So this time, anatomy and surgery developed hand in hand and interactively. And mostly anatomy was performed by surgeons. Now, history of surgical anatomy. Now, the term surgical anatomy, the first book with the cover, front cover, surgical anatomy was published by Tolfin. He was the surgeon, anatomist, and obstetrician born in Belgium and to France. Then Ireland, Dr. Coles, he published a book, Surgical Anatomy, and in which he said, among all sciences, anatomy is the most indispensable necessity for surgical profession. And we have to remember Virgil's work. He was an anatomist as well as physician. He published a very bulky volume of surgical anatomy, in which the cover slide saying surgical anatomy was in volume 6 and 7. And to show you some of the pictures from his book, it was pictures including topographic anatomy and surgical anatomy. So this is actually the beginning of surgical anatomy, microscopic surgery. Now some more, this getting more elaborate and getting close to microscopic illustration, but not so much yet. But then what is the difference between the Virgil's surgical anatomy and the Rhoton microneurosurgical anatomy? Well, big difference, as I said, macroscopic photos and Rhoton's surgical anatomy of operating microscopic anatomy. The purposes are similar. of course, picture technique advancing according to the times. Now I talk about the evolution of microneurosurgery. You know, neurosurgery developed in the course of surgery, as you know, of Christian Dandy, and then microneurosurgery developed in the flow of the developing microsurgery. Now, pioneers in microsurgery, I listed here a few. The Nylen is a Swedish otologist. He operated on otitis media using monocular microscope. Then, in the field of neurosurgery, it is Jacobson and Danafy first opened a microsurgical laboratory where Dr. Maris and Dr. Yashagil studied and came back to open their own laboratory and develop the microneurosurgery. You see, the first operation Marcus tumors done by Dr. Kersey, and Dr. Maris operated the removal of the craniopharyngioma. Yashagil, of course, you know, IC bypass surgery. He succeeded in human beings. Of course, neurosurgical or armamentarium and neurosurgery-related technologies such as video, photos, MRI, and CTs are very important and instrumental for the development of microsurgery. Now, this is the first microsurgical symposium in Cincinnati, Ohio, 1971. As you see, faces of pioneers of microsurgery. At this time, not only neurosurgeons, other surgeons from other fields attended, but mostly neurosurgeons. Dr. Rhoton, Yashagil, Hardy, Jonetta, Maris, and from Japan, Dr. Kikuchi. Now, some of the pioneers in microneurosurgery, of course, many others, the Danafy, you know, and Yashagil developed this bypass surgery and microsurgery in every aspect of neurosurgery. Maris is important to notice. He developed bipolar coagulator, hardly famous for pituitary surgery, Mayfield aneurysm clip, but of course, you know, his head folder. Wilson microneurosurgery, pituitary surgery, Sugita also aneurysm clip, head holder, and so forth. ISMA refined microsurgery. Janetta is famous for microvascular decompression surgery. Dr. Sun, my mentor, will tell you in a minute. Dr. Chu, microsurgery. Now, this was a microsurgery symposium at the Cincinnati, Ohio, second one, 1975, where Danafy, Yashagil, Dr. San, Dr. Sugita from Japan were in the photo, in the faculty. Evolution of microneurosurgical anatomy. Now, when I was a resident at the Mayo Clinic, we had Professor Yashagil invited by Dr. Sant, and his lecture, he said, I studied anatomy in the laboratory whenever I had time, stressing the importance of learning anatomy. And his comment was confirmed at the time when I had a chance to meet him and interviewed him in 2005 in Japan at the time of a Japan Neurosurgical Society meeting. Now, Dr. Yashagil published neurosurgery in 4 volumes, actually 6 books, of which 3 books have a cover titled Microsurgical Anatomy. Especially, I was impressed by the Vessel System and Volume 1 and vessels, and because I was very much interested in doing aneurysm surgery at that time. I cannot skip, of course, mentioning about Professor Rhoton. According to Professor Matsushima, a tradition of the research theme of Dr. Rhoton classified into 5 stages. The first stage, the dawn of the microneurosurgical anatomy. The rest of the stages will be mentioned by Professor Matsushima after me. I was involved. I will talk about the first stage because I was involved to some extent in this stage of Dr. Rhoton's microneurosurgical anatomy. Now, Dr. Rhoton, before joining Mayo Clinic, he took 1 year NIH fellowship in neuroanatomy, Washington University. He did animal experiment dealing with the cranial nerves already. He published some papers on these.
Examples are dealing with acoustic neuroma, which is a tumor on the nerve of hearing, and it involves the facial nerve, which if the facial nerve is lost, it leaves a disfiguring facial sagging face with inability to close the eye and smile. And during my training in dealing with these tumors, I never saw a facial nerve preserved.
Now, this paper, I have Dr. Rhoton dissect the cadaver and first publication on nervous intermediates. And this was the first paper in the entire series on microneurosurgical anatomy of Dr. Rhoton. As young as they were, as you see. Now, we resident fellows at the Mayo Clinic work with Dr. Rhoton, and mostly on cranial nerves. And as published here, you see several papers. Dr. Rhoton left Mayo Clinic in 1972 at the University of Florida. Now, please allow me to talk about my three respected mentors in my neurosurgical career. Dr. Sant and Dr. Rhoton, I worked with them at Mayo Clinic. At Shinshu University, I worked with Dr. Sugita. Now, working period with them was not so long, but we were in collaboration for many years to come until their death. Now, we, Shinshu University, sent 6 fellows to Rhoton Laboratory, and this is one of Dr. Gibo's first paper dealing with perforating arteries from internal carotid artery. This helped develop my concept of carotid cavity aneurysm of ICA. We did some more studies on this anatomically. And this is another example. Dr. Kakizawa's work with Dr. Rhoton. Dr. Rhoton likes computer graphics. And this is the a very new field we thought, and it is still continuing. Now, in summarizing what I said so far is the microsurgical anatomy originated, of course, developed from the time of Greek anatomy and 18th century surgical anatomy, and to go over to microneurosurgical anatomy. Now, I'd like to talk about the purpose of anatomy. And regarding purpose of anatomy, initially in Greek period, anatomy was studied on the purpose for scientific pursuit. In the Renaissance period, medical education was becoming very important because of the scientific development. And then as the surgery developed, clinical purposes, anatomy for clinical purposes became very, very important. Now, and the final part, I like to talk about future perspective microneurosurgical anatomy. Now, it is important to continue on Rhoton's concept of microneurosurgical anatomy, as Dr. Rhoton said, to achieve accurate, gentle, and safe surgery, and incorporation of new imaging technologies are very important, and it can be utilized in the study of microsurgical anatomy. And I'd like to stress the necessity of microneurosurgical anatomy for new surgical fields such as endoscopic surgery or endovascular surgery and others. And new anatomical field will come to be studied by neurosurgical anatomists, including perforators and tract of the white matter. And finally, for the sake of education, I'd like to share with you the development of computer graphics. Now, this is a paper by Dr. Kakizawa, is Dr. Rhoton, you see, studying a cadaver dissection. At each stage, they took many photos and make this computer graphics, and this is that magnified. And in order to see the other side of this CG, it is rotated 180 degrees to see immediate view of the ICA using a transparency technique. See, 3D scanners becoming important. These 3D scanning of cadaver dissection is very useful. I think the characteristic of this 3D model dry, permanent, freely rotatable, and for use repeatedly. Now, on the basis of skull-base anatomy, CG can be made like this. Subtemporal approach to the skull-base region, retracting the brain, cutting the dura, and also drilling the tip of the petrous bone, cutting the tentorium to expose the trigeminal region and skull-base region like this. Now, for the brainstem, very complex brainstem anatomy, we proposed 1993 safe entry zone to the brainstem. And this can be demonstrated by using computer graphics. Although it can be refined more. And the fiber tract, each stage you take many photos and to construct this computer graphics of the tract of the brain. Just to show you future or using our concept at Shinjuku University, utilizing this CG model, you see, integrating all information, scan images, remote information from outside the operating theater. Of course, textbook and CG model will be effectively used in the operating theater. So in summary, anatomy and the Greek age is introduced, and the modern anatomy and surgery reciprocally developed. And surgeon performed most of anatomy. The concept of microneurosurgical anatomy originated in the surgical anatomy in the 18th century. Microsurgery flourished, especially in the field of neurosurgery, and CG will be important for microneurosurgical education in the future. I'd like to deeply acknowledge these scientists and thank you very much for your attention.
Professor Kobayashi, that was a wonderful presentation that I thoroughly enjoyed, as I'm sure many others. Thank you so much for your service as president of the society, and thanks for a great presentation. Dr. Matsushima, please share with us your presentation.
Yeah, thank you very much, Joan, Mr. Chairman. Hello, ladies and gentlemen. I am Toshio Matsushima from Japan. I was one of the Dr. Rhoton fellows. I worked at the Rhoton first from 1980 to 1982. After that, I continued to work with Dr. Rhoton for about 35 years and published several papers with him. The title of my today's speech is Dr. Rhoton's Philosophy, Achievement, and Legacy. Dr. Rhoton passed away in 2016.
Dr. Matsushima, you are showing your PowerPoint.
Please share your screen. Yeah, Dr. Matsushima, please share your presentation.
Oh.
Share your screen.
Not, doesn't work?
We're not seeing it yet. Just try again.
Okay, let me see.
In the meantime, for the audience, if you have any questions, please feel free to type on the questions and answers tab, and we will address any questions or selected questions, if there are several, at the end of each presentation.
Dr. Matsushima, if you look at the bottom of your screen, there should be a green box that says share screen.
I know the green screen, but how can same thing?
We also have your PowerPoint presentation available, so we can share it on our end if you prefer that we do it. And then you can just...
Yeah. When we did I don't know how.
Perfect. Oh.
Yeah. Okay. Show the recorded.
We...
It's not this one. This is different one. It's not this presentation.
Okay.
I don't know how to. Yeah, coming.
There you go.
Yeah,
That's
coming.
good.
Sorry.
No problem.
Okay. Yeah, I do.
Thanks, Dr. Matsushima. Now we are seeing your presentation really well.
Okay, thank you. I'll start again. Dr. Rhoton passed away in 2016. 4 years has passed already. Now the name Rhoton may remind the young generation Rhoton's microdissectors or textbook Rhoton. Dr. Rhoton is a great pioneer in the study of the microneurosurgical anatomy. He reported over 500 publications, including 160 original microneurosurgical articles on the brain anatomy. His textbook Rhoton is a distillation of the 40+ years anatomical study. It has been translated from the English in Portuguese, Chinese, and Japanese. It is widely considered to be Bible for neurosurgeons worldwide. He left the Rhoton collection in WNS2. First, I'm going to introduce Dr. Rhoton's biography until he moved to the University of Florida. Then I would like to talk on 3 subjects: his character and philosophy, his achievement and legacy. Dr. Rhoton was born in 1932 in rural Harvin, Kentucky, in a log cabin without electricity or plumbing. He often told us that the midwife who attended his birth did so in exchange for a bag of corn. These 2 pictures are early home and elementary school, which appear in the textbook Rhoton. His mother was a teacher, and his parents moved to Ohio for his education. But he had to sell papers on the street corner when he was 10 years old. His diligent and industrious personality must have been formed as a result of this hard-scrabble upbringing. I'll show the video of his interview, which was made at the University of Florida.
I was born in Harvin, Kentucky, in the poor part of Appalachia in the hills, in a log cabin delivered by a midwife in return for a bag of corn. There was no electricity. We carried water from the springs in the back of the house. I went to a 2-room schoolhouse, a dilapidated 2-room schoolhouse in the hills, and I don't think I heard the word physician during my early life. There were no doctors in the hills, and it wasn't until some years later that my parents moved out to Ohio, and we became city dwellers.
When he was an Ohio State University student, he watched the brain operation performed on an animal in the laboratory. He was amazed when he witnessed how a tiny lesion improved the animal's behavior. He declared that the brain is the source of the mystery and wonder. Mind and brain are source of the happiness, knowledge, and wisdom. He wanted to work with the brain and to become a neurosurgeon. A few years later, he was attending Washington University Medical School. His training year was in early 1960s. In those days, the brain surgery was primitive and risky. He wanted to treat his patient as well as he could. I prepared the movie, but Dr. Kobayashi showed same movie, so I skip out. He became eager to establish a roadmap to access the region. At the Mayo Clinic, Dr. Kobayashi of Shinshu University from Japan was a chief resident there around the same time. They published the paper Nervous Intermediates together in 1968, about 50 years ago. That was the dawn of the microsurgical anatomy. Dr. Rhoton told us that microsurgical anatomy is a roadmap for applying microsurgical technique. He thought that the combination of the knowledge of the microsurgical anatomy and the use of the operating microscope has improved the technical performance of the many neurosurgical procedures. He had a desire to build a program to create roadmap. He was offered an option of the moving to the University of Florida to develop a program from the ground up. He chose this known path as a way to begin and grow the training and educational environment he envisioned. He moved to the UF in 1972 and became the chief of the division of the neurosurgery in the Department of Surgery. Next, Dr. Rhoton's character and philosophy. Dr. Rhoton left many words which has remained in our mind. His character and philosophy can be glimpsed in those words. They reveal his passion for microneurosurgery and infinite love for humankind. Be more accurate, gentle, and safe is a famous phrase which expresses his thought on the most important of the microsurgery and microsurgical anatomy. Dr. Rhoton frequently used this slide. Dr. Rhoton often told us, keep working hard. He was a hard-working person. Dr. Day, who was the first UF neurosurgery resident and worked for a long time with Dr. Rhoton, described him a hard-working, diligent, and patient individual. Dr. Rhoton did not play golf, did not drink alcohol, and did not smoke. Dr. Rhoton also told us, we want perfect anatomical dissection because we want perfect surgical operation. Dr. Martin, one of the Rhoton fellows, described that the work in his lab was guided by the concept of the perfect Rhotonian image. It demanded the right specimen, right dissection, and right picturing. The amazing he sensed when he saw animal operation in college led him to say, the brain is the crown jewel of the creation and the evolution. It was this passion for the brain That was a driving force behind his neuroanatomy research. Later years, in his lecture, he often told us a story that we need both
surgeon is like
compassion.
the giant oak tree that sends its roots deep into the earth to the source of love and kindness, from which we constantly replenish our ability to treat our patients with compassion, and it makes us reach out with our limbs and branches to assist the world with skill and knowledge.
Although his renown rested on the repetition as a researcher, Dr. Rhoton was also a devoted educator. He had been interested in teaching since his youth. During his medical school, he was a very intelligent student who enjoyed teaching. In fact, he met his wife, Mrs. Joyce Rhoton, when he was asked to help the study of the fetal circulation by occupational therapy students. One of the major reasons he moved from famous Mayo Clinic to the University of Florida was to develop a center for training neurosurgeons in microsurgical technique. Next, Dr. Rhoton's achievement. They include first, the study of the microsurgical anatomy. He studied various areas of brain and published over 500 publications. Secondly, education of his research fellows. He worked with 119 young doctors and educated them. Thirdly, he also contributed to the education of the countless number of the neurosurgeons globally through many dissection courses, lectures, and publications. Fourthly, development of the microsurgical instrument. He developed many kinds of micro instruments for brain surgery. Rhoton's microdissector is the most famous. After moving to US, Dr. Rhoton operated the Rhoton lab in 1975. He started the 5-day microvascular and dissection course to train neurosurgeons. His anatomical research was also accelerated. He and his fellow established the research methods such as arterial and venous injection methods. Dr. Evandro Oliveira and I worked together in 1981. Around that time, we started to inject the blue latex into the vein, removal of the arachnoid membrane, and taking the color slide. One of the most important elements in the Rhoton Lab's paper was the illustration. 4 medical illustrators worked over the 41 years. The illustrators in the right upper corner are David Peace and Margaret Robin Berry. In the early years, the glossy print of the black and white photograms were retouched by medical illustrators to bring out important anatomical features. Dr. Rhoton published over the 500 publications, textbook Rhoton, and Rhoton collection. In 2018, we reviewed the 160 original articles, categorized them chronologically, and published in Journal of Neurosurgery. The front cover of the JNS issue shows the illustrations from articles from Rhoton Labs. We separate the papers from Rhoton Lab into 5 stages. The first stage, in the latter half of the 1960s, Dr. Rhoton started his anatomical study on cranial nerve using monkeys at Mayo Clinic, then using autopsy brain and temporal bone. He focused and reported the detailed anatomy of the cranial nerve with variation. He also started his anatomical study for the field of his major surgery, pituitary tumor surgery, aneurysm surgery, and microvascular decompression. One of his great work in the study of the facial nerve on the facial nerve for acoustic tumor surgery. He found that the facial nerve was often stretched over the anterior half of the tumor capsule. He stated that this was because the facial nerve mostly caused in the anterior superior part of the internal auditory canal, and the tumor usually originated from the vestibular nerve causing in the posterior part of the canal. Let's look at another field of his major surgery. The slide shows the figures of the Sera Trushka for the pituitary tumor surgery. He demonstrated the easily understandable, beautiful color illustration figures of the pituitary gland to the cavernous sinus. He also studies the cerebral arteries with perforators for aneurysm surgery. The MVD is also one of Dr. Rhoton's major surgeries. After Janet's report on the MVD, Dr. Rhoton studies the three cerebral arteries, especially their relationship to the cranial nerve in the CP angle. Then he proposed rule of three in the CP angle. When the SCA compresses the trigeminal nerve, trigeminal neuralgia develops, and the AICA does the facial nerve, and facial spasm develop, and PICA does the gross-pharyngeal nerve, gross-pharyngeal neuralgia develop. When Dr. Rhoton and I studied the fourth ventricle and the veins of posterior fossa, Dr. Rhoton proposed the rule of three in the posterior fossa. In the second stage, mainly in 1980s, Dr. Rhoton extended his study to other areas for the basic anatomy for general neurosurgery. The topics include the ventricle and venous system, etc. Regarding the ventricle, he collected all anatomical information, including the neural structure described by the anatomist and the related vessel described by the radiologist, and composed a single structure from them for neurosurgeons. In the third stage, mainly in 1990s, Dr. Rhoton again studied the cavernous sinus, temporal bone, jugular foramen, and etc. because there was some new development in skull-based surgery, such as Dorrent's approach. In the fourth stage, since early 2000s, Dr. Rhoton began to study internal structure of the brain using fiber dissection techniques. Several studies were reported using the combination of the fiber dissection and diffusion tensor images. Treatment methods have become increasingly diverse. In the fifth stage, several labs projects that dealt with new methods, such as the endoscope, neuronavigation system, vascular surgery, and deep brain stimulation. Dr. Rhoton compiled the effort of the 35 years of anatomical research into a single textbook, Rhoton. This textbook has been translated in Portuguese, Chinese, and Japanese. In Rhoton's lab, a tremendous volume of the descriptive photogram of the dissection were produced. He considered how this data could best be handled down. He started to work on Rhoton collection in 2010. He discussed with Dr. Robertson and Dr. Sorensen. As a result, Rhoton collection website was made. Next, let me talk about Dr. Rhoton's contribution to the neurosurgeon education. He made a significant contribution to it. Dr. Rhoton hosted and organized numerous dissection courses. One type was a 5-day microvascular and dissection course held in his lab at UF. And the other type was a cadaver dissection course held at the WNS, CNS, and North American skull-based meetings. The most left slide shows a monthly 5-day microvascular and dissection course in all Rhoton labs. Every month, the 5-day course was held for more than 10 years. Over the year, more than 1,000 neurosurgeons from all over the world attended from the course. The course made the Rhoton lab in US famous in the world. He performed the anatomical study with 119 young neurosurgeon research fellows for about 40 years. About 100 of the fellows were from outside the USA. He taught them not only the surgical anatomy, but also his passion for the microsurgery and his philosophy. It was Dr. Rhoton's hope that his foreign research fellows would return to their own country and teach others and share the knowledge there. The picture was taken at the celebration of the Dr. Rhoton's 40 years at the UF, which was held in 2012. At that time, he was pleased to learn that about 40 of the 100 foreign fellows had become professors. Rhoton Lab at UF served as a microsurgical training center for many neurosurgeons from all over the world. His research fellow has established similar laboratories all over the world, inheriting Dr. Rhoton's lab system and his spirit. Japanese fellows started the Japanese Microsurgical Anatomy Seminar in 1986, 35 years ago. The first one was held at Kyushu University, Fukuoka, Japan. Evandro joined the Japanese fellows far from Brazil. This seminar has been held annually, and this year, the 34th seminar will be held. The seminar was very popular, especially in 1990s in Japan, and more than a few thousand of the proceedings were sold every year over 10 years. The first international symposium on the microsurgical anatomy was held in Matsumoto, Shinshu, Japan in 2002. You can see Dr. Rhoton, Evandro, Ardinaro, and Dr. Wen receiving the support from the Japanese Society for Microsurgical Anatomy, and Dr. Kobayashi, the president of the Japanese Neurosurgical Society in 2002. I organized and held the first international symposium when Dr. Rhoton was invited to annual meeting of Japanese Neurosurgical Society. After that, 3 research fellows, Evandro, Ardina, and I decided to continue the international one. The 3 were research fellows at the same time in 1981. Evandro, are you hearing me? We grew up under Dr. Rhoton, and we are working together for 40 years. After that, we organized and held 5 more international symposiums, 4 times in Turkey and 1 time in Brazil. These are photos of the first Rhoton Society meeting, which is also the 7th international symposium on the microsurgical anatomy. I would like to explain the relationship between the 2 meetings. The international symposium was carried out by 3 1981 Rhoton fellows, Evandro, Ardina, and myself. Professor Rhoton passed away in 2016, and WNS 2016, Dr. Joan Fernandez Miranda, the president of this meeting, proposed the establishment of the Rhoton Society for continuing education of the surgical anatomy. Then the first Rhoton Society meeting was held in Tianjin, China by Dr. Tong. The second meeting is a virtual meeting due to the coronavirus infection. But thanks to it, the lecture was sent out all over the world. The Rhoton Society meeting will continue to be carried out by Rhoton fellows. Right upper corner picture was taken a month before Dr. Rhoton's death in January 2016. He told me about next few years' plan enthusiastically he left us the word, there is no finish line. Dr. Rhoton, thank you very much for teaching us. We will never forget you and what you did. Thank you for your attention.
Thank you, Thank you very much, Dr. Matsushima. That was a very inspiring lecture, great review of Professor Rhoton's life and legacy. Greatly appreciated. So with this, we conclude our first part of the meeting, presidential address and a special lecture by Dr. Matsushima. And I'm pleased to tell that we are on time. So thank you to both of you. And we're going to move on to the next panel on cerebrovascular samurais that is going to be moderated by Dr. Wang from Brazil and Dr. Abe from Japan. So please come up, let us show you, and we can start as soon as you want.
Hello, everyone. Good evening. Good evening here in South America, and good morning in Asia. And let's just act like samurais. It's a cerebrovascular samurai. So let's just go straight to the point. I would ask Professor Inoue to give the first talk, Battlefield of Aneurysm Surgery, the surgical anatomy of the arachnoid membranes and cisterns. Is Professor Inoue online?
Yes.
Oh, great.
Can you see my presentation?
Not yet.
No, not yet.
左下のビデオを開始。
We cannot see you either. Megan, Ruth, can you please help us see if we can see Dr. Oh, there you go.
Okay.
I guess we don't need to see you, Koei. We can see your slides. Thank you.
Okay. Okay. Thank you, Chairman and Professor Fernandez Miranda. It's my great honor to have an opportunity to make my presentation here. Today, I'm talking about surgical anatomy of the arachnoid membranes and cisterns. Especially, I focus on the supratentorial cisterns for anterior circulation aneurysm surgery. There are two types of arachnoid membranes, the outer arachnoid and inner arachnoid membranes. Outer arachnoid membrane is thick and covers the whole brain. Inside the cistern, there are numerous trabecula. The trabecula support arteries, veins, and nerves. In some area, numerous trabecula form the inner arachnoid membranes. Here we see right front and temporal lobe. It is easy to house and split the outer arachnoid membrane. This is easy, quick, and safe technique when we start to open the Sylvian fissure. This is an illustration of the cisterns and membranes. The outer arachnoid membrane covers the whole brain, and inner arachnoid membranes are in the cistern. 11 inner arachnoid membranes are in this area. Today, I want to introduce some of them. This lateral view of the left cerebral hemisphere Sylvian fissure has 4 major rami. That is the stem, horizontal ramus, ascending ramus, and posterior ramus. Inside the fissure, wide cistern is spreading. The Sylvian cistern can be divided in 3 compartments. the anterior, posteromedial, and posterolateral compartments. They were also called sphenoidal, insular, and opercular compartments. In this picture, the operculum was totally removed from the left cerebral hemisphere, and whole insula is revealed. Insula is the medial wall of the posterior compartment of surveillance system. Before I start to split the Servian fissure, I always find the anterior Servian point. The four rami concentrate at one point. This is the anterior Servian point. The lower angle of the pars triangularis also shows the anterior Servian point. This point shows the widest space of the Servian fissure, so it is the best point to start split the Servian fissure. The deep side of the anterior Servian point corresponds to the anterior short gyrus and lumen insula. So when we approach to the basal cistern, the stem should be open. On the other hand, when you need to approach to the insular area, the posterior rams should be opened. This is an illustration of coronal section of the Servian system. There are three inner arachnoid membranes: lateral, intermediate, and medial Servian membrane. Especially intermediate Servian membrane can be a good landmark when we open the Servian fissure. The posterolateral compartment has tiny space and dense trabecula. On the other hand, the posteromedial compartment has wide space and sparse trabecula. The intermediate Servian membrane is the boundary of the two compartments. Here we see the left Servian fissure, high magnification, frontal lobe and temporal lobe. This is the outer arachnoid membrane, and here, this is the posterolateral compartment. It has tiny space and dense trabecula. Here we see the intermediate Servian membrane, and I cut, and we can see the posteromedial compartment. Outer arachnoid membrane and posterolateral compartment, intermediate Servian membrane, posteromedial compartment. In the anterior compartment, the proximal Servian membrane arches across the proximal part of the Servian cistern from the orbital gyrus to the medial temporal lobe. This membrane is border of the Servian cistern and carotid cistern. Here we see the proximal Servian membrane. This is the outer arachnoid membrane. To complete opening the Servian fissure, I cut it so I get access to the carotid cistern. Next, I'm talking a little bit about pericallosal and lamina terminalis systems. We often use basal interhemispheric approach for ACOM aneurysm surgery. These are axial section of the MR image. And in this approach, the pericallosal, these systems have a narrow compartment in the shallow area and wide compartment in the deep area. From the point of view of the anatomy of the cistern, the Sylvian and pericallosal cisterns are similar. The shallow part of the cistern has tiny space and deep part has wide space. So I usually approach to the deep cisternal space first, and then I dissect the arachnoids from both inside to outside and outside to inside to expand the surgical corridor. These are the inferior view of the basal cistern. The relationship of the basal cisterns and inner arachnoid membranes are complicated. The understanding of the anatomy of the carotid cistern and related inner arachnoid membrane is important for anterior circulation vascular surgery. Leakage membrane is the most famous membrane. It has two components, the diencephalic membrane and mesencephalic membrane. These two membranes border the interpeduncular cistern here. The diencephalic membrane extends upwards and attaches to the third ventricle floor. The mesencephalic membrane the mesencephalic membrane has membranous part and trabecular part. Membranous part and trabecular part. It extends backward and attaches basilar artery, PCA, oculomotor nerve, and so on. This picture shows developed mesencephalic membrane, but this picture shows poor developed mesencephalic membrane. In the endoscopic third ventriculostomy, we can also see the mesencephalic membrane. This is a cadaveric picture. And in this case, here we see poor developed mesencephalic membrane, membranous part and trabecular part. Here we see the relatively developed membrane here. The oculomotor nerve is surrounded by the arachnoid membrane. These structures are reported by Dr. Matsuno in 1988. The mesencephalic membrane extends laterally and attached to the oculomotor nerve. The membrane further extends laterally and attached to the tentorium and the medial temporal lobe here. This is an ICP-com aneurysm case. Here we see the mesencephalic membrane extend laterally and attached to the oculomotor nerve and medial temporal lobe. The mesencephalic membrane is the inferior border of the carotid system. In this case, the temporal lobe should be retracted posterolaterally to get the wide retrocarotid space. So it is important to dissect the mesencephalic membrane which attached to the oculomotor nerve and medial temporal lobe. The medial border of the carotid system is the medial carotid membrane, which separates the carotid system and chiasmatic system. After the cut the membrane, we can get access to the interpeduncular system through the carotid system. In the carotid system, there is an intracarotid membrane, which extends downward from the inferolateral surface of the optic tract and attached to the medial temporal lobe. It also attached to the carotid, posterior communicating and anterior choroidal arteries and their perforating branches. Here we see the intracarotid membrane. This membrane and trabecula should be cut to be free the arteries and get clear surgical view. I cut all of this membrane. So I introduced some supratentorial cisterns and inner arachnoid membranes. Understanding of the microsurgical anatomy of the arachnoid membranes and cisterns are important and useful for microsurgery. Thank you so much for your kind attention.
Okay. Okay. Thank you so much, Professor Inoue, for your wonderful presentation. Now we have the honor and privilege to have the next speaker, Dr. Art Day. He was Dr. Rhoton's first resident in Gainesville at the UF, a world-class cerebrovascular neurosurgeon and a pioneer of paraclinoid aneurysm surgeries. So please, Dr. Day.
Can you hear me?
Oh, yeah.
Hello, Dr. Wynn, and hello, all the Rhoton Fellows. It's so nice to see you, and the honor is mine to be included in this wonderful group of people here. I came to Gainesville in 1972, shortly after Dr. Rhoton had arrived, and he met me actually at the airport when I landed, and I was one of two applicants for two residency positions. So the competition for being accepted was very high. But fortunately, he chose me, and it changed my life. It was a wonderful experience, and also wonderful to get to see each of you, or most of you, come through the time that you were there, and to share that world with you during our early careers. I stayed there until almost 30 years, counting my residency, and be able to spend that much time with him and his fellows was truly one of the most wonderful things that could ever happen to me in my career. I'd like to talk to you about my journey through the paraclinoid region And part of it, of course, was Dr. Rhoton's journey. So I'll get started with the details of how I reached where I got in this area with him. In 1982 or 83, I began focusing on my cerebral vascular work and subsequently went and spent a little time with Dr. Yazergil and Dr. Thorsont and Dr. Drake, and of course, hearing what they had to say and then coming back to the Rhoton laboratory and anatomy lab enabled me to start bringing some concepts that they had into his area. And I became very interested in the carotid artery and in the visual system and started seeing a number of cases with visual presentations, and then started to pay attention to the anatomy to a much greater detail than had been described before. This picture on the right, where my, if you can see my marker, is the image of what the cavernous sinus and what the carotid artery and what the clinoid process looked like at that time. And that was, there were only two places in this region. There was above the clinoid and there was below the clinoid. One never went below the clinoid because the cavernous sinus was there and very dangerous. And one never went into the clinoid because we didn't have the understanding of the way the dural membranes folded and their relationships to the vascular and nervous structures. I then put my data together over my first 80 cases of aneurysms in the region, and using his terminology of the ophthalmic segment, came up with a distribution of aneurysms divided into the ophthalmic and superior hypophyseal varieties. This was based on the concept of, shown on this anatomy slide, of that there was a membrane through which the carotid artery entered the subarachnoid space. We didn't necessarily call it the dural ring, but it was clearly a membrane that slanted. And above the membrane was the ophthalmic region with the ophthalmic artery, and below the region was the cavernous carotid artery. At first, there was no knowledge or no recognition that there might be a segment in between that and the cavernous sinus. And then by applying the Rhoton's rules of curvatures, an artery that curved like this and had a branch was a generator of an aneurysm in this particular location. And then another of other series of aneurysms that didn't fit this pattern came off the medial surface, where the origin of the superior hypophyseals came off the medial carotid artery, which what led to the delineation of two types of aneurysms in the region, one associated with the ophthalmic artery and one associated with the origin of the superior hypophyseal artery in this small groove on the medial surface called the carotid cave. So after reporting and doing a number of cases, in over 100 cases of these, it became apparent that the anatomy was more complex than this simple diagram or anatomic specimen of above or below the dural ring would indicate. And about that time, at the same time, Dr. Vinko Dolenc was explaining or talking about the extradural approach to remove the anterior clinoid process. And I went and visited him with several of my colleagues to try to get an understanding of that. And then when you saw what he was thinking and you realized that the bone could be removed without entering the brain, and that when you did the bone removal, you could make sense of all these structures that were in this close area, then it really, really dramatically changed my view and the more details of this region to accommodate more complicated lesions. In essence, the concept was that if you looked at a lateral view of the carotid artery with the clinoid covering it, that this bony structure is covered by periosteum. Periosteum, of course, is the same as dura on the inside of the bone. And if you came from extradural and took the bone out, but left the periosteum alone, you could see a segment of the carotid artery between the dural ring above and the cavernous sinus below. And this is a picture of an anatomic specimen of that, with the then opening the subarachnoid space. This segment, then the clinoidal segment, became the gateway of the exposure of the region that really enables you to see the entire course of the optic nerve, and as long as there was a subarachnoid space extending through there, and opened up this region dramatically for surgical intervention for aneurysms and tumors of the area. It also then allowed a clearer separation and explanation of the aneurysms that were in this region, those that were truly in the cavernous sinus, those that arose above the cavernous sinus but below the subarachnoid space, those in the ophthalmic segment, the first segment of the subarachnoid space, and those in the communicating segment, in many cases associated with a short ophthalmic segment that placed them close to the clinoid process. So it led to a reclassification of the, once the clinoidal segment was clarified, a reclassification of aneurysms. On the left is those in the ophthalmic segment, which includes the ophthalmic artery as number one, the superior hypophyseals as number two, and a third variety that began to spring up, a site of dissections or blister aneurysms on the dorsal surface of the carotid arteries called the dorsal variants. And in those, then we started to see a lesser number, about 20% of the aneurysms that appeared to be paraclinoid actually arose below the dural ring. And in that case, some of them arose from the anterior lateral surface of the carotid as it was ascending underneath the optic nerve, and some arose more distally below the diaphragm and projected into the suprasellar space, which we called the medial and anterior lateral variants. Learning how then to expose this surgically was our challenge, to allow the accurate clipping while preserving the vision and the blood supply to the optic nerve in that region. The surgery portal then was divided into 3 stages. One, the external bone needed to in the craniotomy. The second, the ridge of the removal, including the roof of the greater wing of the sphenoid, as well as the base down to the clinoid, all done extradurally. And then I chose, after seeing several individuals have major problems with rupturing aneurysms, removing the clinoid extradurally, and seeing the relationship of the clinoidal segment to some of these aneurysms, just made a point of learning how to do the final stages of the clinoid intradurally while I was looking at the artery itself and at the aneurysm. So on this schematic, on this bone specimen, going down the clinoid to the tip, taking the roof of the optic canal, and then taking the optic strut out, enables you to communicate the superior orbital fissure and the optic canal widely, and then be able to loosen up through an incision in the optic nerve sheath, the whole area, to relax and see the area quite well. These are sort of the stages that became developed as routine for any of the carotid, proximal carotid artery aneurysms, and that would be a posterior reflection of the temporalis muscle, as Yazergill described, the ability to move the orbital rim if we wish to, the removal of the sphenoid ridge, and then visualizing the posterior periorbita down to the base of the anterior clinoid process, and taking some of the superior or greater wing of the sphenoid to loosen the superior orbital fissure as we went deeper, and then opening the dura, splitting the sylvian fissure, and looking at the medial portion of the sphenoid ridge with the clinoid still intact but underneath the dura, incising over that region, seeing the stump of now the anterior clinoid process and the periorbita that you resected extradurally, and then removing the whole course of bone covering the optic canal, and then drilling out the anterior clinoid process and the optic strut, gave a phenomenal view of the region and really widened my understanding of the variations even more, and broadened the technical ability to fix these much more accurately. So in essence, this would be the end stage operative view after the clinoid would be removed, and then an incision would be made along the optic nerve in the subarachnoid space diverticulum, and we would grab this stitch, this corner of the dura right there, and reflect it into this cavity that was left, and that would unfold this entire area and see the whole carotid artery and the dural ring, and have the ability to circumferentially resect the ring as needed. Here's an example of how that now is done in a very straightforward way. Here's a typical ophthalmic artery aneurysm on a 3D reconstruction with the dent in it anteriorly where it comes out underneath the falciform fold, and the optic nerve is markedly kinked in that area where it's traveling with the ophthalmic artery, and then has to come out of that canal to get into the brain. This is a view of the preoperative or the intraoperative view before the clinoid is taken out. The view after the clinoid is taken out and the optic nerve sheath is opened, and then the ease in which you can see the neck of the aneurysm, and then the clip applied in a very straightforward fashion with that exposure. Here is the case actually as we're doing the operation. The sylvian fissure has been split now, and the carotid aneurysm has been visualized. Now we're going to coagulate the dura over the remaining stump of the anterior clinoid process, and you can see now the going past the remnant of the clinoid process, so we can now open a linear pathway across the roof of the frontal fossa along the top of the clinoid, and then reflect the two leaves of the clinoid, of the dura covering the clinoid to see the stump as we go. Now we're scraping off the bone, the dura from the bone to see the residual anterior clinoid process, and then we will retract it with stay sutures to see this. This is the remaining anterior clinoid process. It can, I used to drill the whole thing, but it became easier to just bite the external surface and then drill it when it got down deeper. And that way I avoided some of the potential heat exchange that might be dangerous. Now I'm opening the optic canal, the roof, and completely exposing the course of the optic nerve from the globe all the way into the intracranial space. The optic, the anterior clinoid is now has been curated away now and released. And I see the base of the anterior clinoid process and drilling off the optic strut to end my exposure for the ophthalmic aneurysm. And once that's done, now this space has been created, and you can make a linear cut along the optic nerve sheath, and you really will see where the visual compression from this aneurysm is right along here at the as it goes over the aneurysm out across the falciform fold. So opening that plane sharply lets you release the optic nerve from being compressed in that pathway at that site. And then it allows you to take this dura here, this sleeve that used to cover the top of the clinoid, put a stitch in it, and retract that towards the space vacated by the clinoid process. And now your aneurysm is broadly exposed with very good visualization of any small perforators that might be going to the optic nerve, the origin of the ophthalmic artery, etc. So going through these adhesions, you have to be careful that you don't disturb a potential perforator coming off the top of the ophthalmic artery in this region that might be running to the nerve. You define your neck now very clearly of an ophthalmic aneurysm. And now it's a matter of a straightforward application. I use now gentle curved clips on this aneurysm to place it in the area and then rotate it slightly to accommodate for the curvature immediately of the artery as it goes around the corner. And of course, this is above the plane of the superior apophyseal artery, so it's not going to place those vessels in danger. And when you're done, then the marked decompression of the visual system that allows this approach to work so effectively. Now, for superior apophyseal artery aneurysms, the anatomy is more complex, And that is, that's where the exposure of the, of opening up the dural ring is done by opening this region just like for an ophthalmic, but then circumferentially sectioning the dural ring from adjacent attachments. You can free up the carotid artery and mobilize it and separate and identify the origin of the superior apophyseal arteries much easier. And that then makes the clipping in a much more straightforward fashion for these often very broad-necked and complex aneurysms. Here's an example of a giant superior apophyseal artery aneurysm causing marked visual loss bilaterally with slow flow in it on this lateral arteriogram and the 3D reconstruction of formidable lesion to reconstruct the lumen. I suppose nowadays most people would try to treat this with a stent and a pipeline in the hopes that that would take care of the aneurysm, and indeed it likely would in many instances, but it would not acutely decompress the visual system. This picture on the right shows the aneurysm that now that's been clipped. It has some images over it, but here's the operative view of what it actually looks like in the operating room, and how, again, that same exposure facilitates the management of the visual system. Is first of all clarified, so I know exactly where the optic nerves and the chiasm are and the perforators, and then go about doing the same type of extradural and intradural preparation. Finally, then going intradural to remove the stump of the anterior clinoid process. There it is. It's, in this case, a very thin remnant of a clinoid, easily resected down to its base and then drilled out the rest of the way as needed. Once the clinoid is removed, then the stitch on that on the dural ring allows you to retract down. And now here is the ophthalmic artery coming off. I'm sectioning the dural ring circumferentially underneath the ophthalmic artery to allow me to see around it and mobilize the carotid to see the superior apophyseals in a much better method. Going medially to that vessel, now I'll see the superior apophyseals lie right in this region, and cutting the dural ring while displacing those vessels will make sure that when I put a clip across this region, I will not disturb them to injure the chiasm, or to give me the lowest chance of injuring the chiasm. So now the aneurysm is, the base has been prepared, and I have the cervical carotid artery exposed in the neck for proximal control. You'll see now how the view of the aneurysm is dramatically changed by preparing this region. We'll take our cotinoids off, and you'll see the aneurysm now. I'll free it from it's stuck to the surface of the diaphragma cell. I have a stem of the artery now visualized. A temporary clip goes on the ipsilateral A1, and the proximal carotid in the neck is clipped, but the PCOM and the ophthalmic artery are still open. Now the aneurysm has been punctured and collapsed after it was freed up, and now you can see the course of the normal length of the artery that has to be reconstructed. Now taking advantage of the laxed artery, I can free up and identify the posterior communicating and the anterior choroidal artery draped across its back surface, and the end of the aneurysm here and the end of the aneurysm there. I have gone to a stacked clip technique because you'll see the difficulty of putting a longitudinal fenestrated clip can be quite cumbersome. So this one I use to get under control, but eventually we'll remove it and simply stack fenestrated clips along the entire course of this artery, making sure that none of them embarrass the choroidal or posterior communicating artery or any superior apophyseal arteries that may be incorporated. Then the temporary clip is removed from that structure, and the aneurysm is now markedly decompressed, and the visual system now is back to normal. And in this particular individual, an immediate dramatic improvement in her vision at the conclusion of the operation. So these are just details that have been summarized that took years to master starting with the curves and shapes that Rhoton first described, and then seeing the contribution of many other people, including the discussions with Evandro and with going to Ljubljana and working with other European experts, to where the classic, the characteristics of aneurysms of the paraclinoid region now have very specific details that we can understand and use to manage. First, there's no question that that the anatomic view in the operating room is completely different than that of the endovascular suite. And one really needs to understand it to be able to manage surgically lesions in this area. There are 5 distinct types of aneurysms in the region. Each have their separate microvascular, microsurgical anatomy. Many small aneurysms arise in this region that, because of their relationship of the dura or the fact that they're below the dural ring, do not have a risk of rupture and therefore should not be treated unless they really do represent the anatomic types that represent risk to rupture. And once you are considering doing an operation or treatment, that surgical treatment clearly provides acute decompression of the visual system that endovascular intervention does not, and that it should be considered, in my opinion, in patients presenting with visual loss from any paraclinoid aneurysm. Thanks again very much, Juan, for allowing me to comment. My best wishes to each of you, to old friends. It's just really a delight to be here with you tonight. Thank you.
Thank you very much, Professor Day. It was a wonderful presentation. And the next samurai is actually myself.
Thanks, sir. That was a great talk. Great to have you.
Thank you.
Sorry, Wen.
No problem. So the next samurai is actually myself. My topic will be the anatomy of the Sylvian fissure and the surgery of the middle cerebral artery aneurysm. I'm just go and hit the presentation. Actually, I was born in Taiwan, but I immigrated to Brazil 46 years ago. And now I live in São Paulo, work at the University of São Paulo Medical School. And these are my mentors, Dr. Evandro and Dr. Rhoton. Here I have I was Dr. Rhoton's fellows from 1993 to 1996. And here's my colleague, Toshiro, and Dr. Kim from Korea. Toshiro's from Kyushu University. Okay, as a samurai, I'll try to go straight to the point. As Professor Inoue already mentioned briefly the anatomy of the Sylvian fissure, I'd just go and review very briefly the anatomy, and then I want to go to the MCA aneurysms. So the Sylvian fissure, we have Sylvian fissure on the basal surface of the brain and also on the lateral surface of the brain. In this slide, we can see just the superficial part of it. But once we remove the arachnoid membrane, we can see the contents of the deep part of the Sylvian fissure located on the basal surface. But if we remove the MCA, we're gonna see the neural structures around this area. But what is the reason why I'm showing this? Because in aneurysm surgery, we have to know where the aneurysm is located and to what structure the dome of the aneurysm is attached to. So we have to avoid that. Okay. So this is on the lateral surface of the Sylvian fissure. This is superficial part. And then this is the deep part. Most of the MCA aneurysms are located in this area related to the inferior trunk or the superior trunk in this area. So now, the MCA aneurysms. We all know the MCA class, the middle cerebral artery is classified in M1, M2, M3, M4. So sphenoidal, insular, opercular, and cortical. But as vascular surgeon, when dealing with MCA aneurysms or other types of aneurysms, we summarize. We want to know the exact location of the aneurysm. Why? Because one, we want to reach it as quick as possible to establish the proximal control, the control of the parent arteries or the parent artery. Two, we want to avoid the fundus, the dome of the aneurysm, because we want to avoid the premature rupture of the aneurysm. So if I know where the aneurysm is, I can go and try to get as quick as possible the parent artery control. And also, if I know where the aneurysm is, where the fundus of the aneurysm is, I have to go the opposite direction to avoid the premature rupture. Okay, I had some experience from 1996 to the current time, a little bit more than 200 MCA aneurysms, but I realized that most of them are located around M1 and the genu of MCA. Only few cases are located distal to the genu of MCA. So I gotta focus on mainly on M1 and the genu of MCA. Okay, here's the AP view of the carotid angiography. So the first question, whenever we see an aneurysm, we don't have aneurysm here, but the first question we gotta make to ourselves is, where is the aneurysm? And to what structure it is related. So here's the carotid artery. Left, here's the A1, here's M1, turning around the insular pole. So this is genu, this is M2, this is M1, okay? Let's say we have a patient with aneurysm pointing upwards, either here or here. To what structure it is related? To what structure is the fundus related? So let's see this slide. Here's the carotid artery, A1, M1, genu. So on top of this, the proximal half of the M1, this is anterior perforated substance. On top of the distal half of M1, this is the insula, anterior surface of the insula. So what is the take-home message? Whenever you see M1 segment, aneurysm from M1 segment pointing upwards, if it is located at the proximal half, it is pointing towards the anterior perforated substance. You have to avoid it. M1 distal half is pointing towards the anterior surface of the insula. So what is danger? And here, you have to avoid the lenticular arteries, okay? What's the danger here? You have to just know there's no lenticular artery over there. Okay, M1 segment, aneurysm pointing down. Is it the same thing if the aneurysm is pointing down over here or pointing down over here? So let's see. Proximal half pointing down. It is attached to what? To the uncus. Distal half pointing down. It is attached to what? To the temporal pole. So whenever you're dealing with aneurysm like this, you have to avoid the temporal lobe. You have to dissect the sylvian fissure through the frontal side, okay? Take home message, aneurysm pointing down. M1 proximal half is pointing towards the uncus. Avoid uncus because the fundus is going to be attached to there, to the uncus. Distal half is going to be attached to the temporal pole. Avoid that. Dissect through the frontal side of the sylvian fissure. M1 aneurysm pointing anteriorly. So is it the same thing if the aneurysm is rising from here pointing anteriorly or rising from here pointing anteriorly? Yes, it is the same thing. Let's see here. Carotid artery, A1, proximal half of M1, distal half of M1, pointing anteriorly. They're all gonna be pointing towards the lesser wing of sphenoid or the superficial part of the operculum of the orbital gyri, or pointing towards the uncus. So So what? Why do I have to know if the aneurysm is pointing anteriorly? What is the danger of this? Because aneurysm pointing anteriorly, it might be attached to the bone. So when you're doing your craniotomy, you're removing your bone or you're opening your dura, the aneurysm might be the fundus of the aneurysm might be very superficial and pointing towards you. So you have to be careful because of about this. Okay, so the take-home message once again, aneurysm pointing anteriorly. To the either proximal half or distal half, doesn't matter. It might be fundus might be related to the lesser wing of the sphenoid bone and or opercula of the orbital gyri and or uncus a temporal pole. Sorry for the mistyping here. Okay, this is theoretically, there might be aneurysms arising from M1 that points posteriorly. So proximal half, aneurysm pointing posteriorly. It's going to be related to what? Let's check here. Carotid artery, proximal M1, posteriorly. It's going to be what? This is going to be attached to the uncus. Aneurysm arising from the distal half, pointing backwards. It's going to be attached to what? To the insular pole. Okay. So once again, take home message. M1 segment aneurysm pointing posteriorly. At the M1 proximal half, it's going to be attached to the uncus. Distal half is going to be attached to the insular pole. Very good. Another region, very important one, is around this area. This is the genu of the M1. The transition between the M1, genu of the MCA, sorry. The transition between M1 and M2. So let's check out the anatomy in this area. So if we see, we follow the Sylvian fissure. If we, the M1, if we follow the flow over here, and then if we don't turn to become M2, what's going to happen? We're going to hit the wall here. What the wall is this one? This is the plenum polare of the temporal lobe. Okay, so why I'm telling you so many things about this, because we're gonna do surgery and we have to know. So first thing, where's the aneurysm in my surgery? Before talking about that, very important landmark. Can you tell, I will ask you a question. What is the best, the most easily identifiable landmark on the perisylvian area? For me, is the pars triangularis. Sometimes very difficult to identify the pars opercularis, precentral or postcentral, but the pars orbitalis and the triangularis is very easy to identify. Okay, once you have it, please see this relationship. This is what? This is the genu of MCA. And genu of the MCA is just a few, more or less 8 millimeters proximal to the tip of the pars triangularis. So once you can identify the pars triangularis, even before opening the Sylvian fissure, you know where the genu is. So that's the importance of this. So in this angiography, where is the pars triangularis? Pars triangularis over here. If you have an aneurysm, MCA aneurysm just over here, it's right under the tip of the pars triangularis. So you have to be careful, because usually we start splitting the Sylvian fissure over here. If the aneurysm is over here, it is just a little bit proximal to where the pars triangularis is located. So pars triangularis is a very important intraoperative landmark for you to tell where your aneurysm is. And usually before doing the surgery, before splitting Sylvian fissure, I always ask my residents to open the carotid cistern to release CSF. So once I have the location of the carotid artery, I have the location of the pars triangularis, I know where the aneurysm is located. I have here, because I am at the pars triangularis over here, I have the location of the carotid artery. So I know, for instance, aneurysm over here is just the half distance between the carotid and the tip of a pars triangularis. So I don't have to look up and down in the sylvian fissure to figure out where the aneurysm is located. Just by looking at the angiogram, and then I have this carotid artery and the tip of a pars triangularis landmark, I know where the aneurysm is. Okay, so what is the take-home message? Pars triangularis is just a little bit 7 millimeters distal to the genu of MCA. Okay, once you start open the sylvian fissure, soon you're gonna see the genu of MCA. And then you have to see on the angiogram where your aneurysm is located. It says proximal, distal to genu, close to the carotid, close to the proximal M1, close to the distal M1, this kind of things. Okay, one very important thing when you want to transport the anatomical information and geographic information into the surgery. On angiogram, you know, this is like AP view. The patient is like in the upright position, but in surgery, the patient is in the supine position. So everything that's pointing anteriorly, we just mentioned, you know, aneurysm pointing anteriorly, aneurysm pointing superiorly, backwards, and this kind of things. We can see pointing anteriorly actually is pointing up in the surgery. Pointing up in angiogram is pointing backwards, okay? Exercise, pointing down, aneurysm halfway between proximal distal M1, pointing down. It is pointing to the temporal lobe. So where is the pars triangularis? It's here. Genu is over here, okay? Pars triangularis over here. Genu is over here. This is even more proximal. So the aneurysm should be down there, but at this location. So let's see. This is a pars triangularis, and this is the aneurysm. This is carotid artery, this is optic nerve, okay? This is how I located the aneurysm. Aneurysm pointing anteriorly, okay? At just the proximal to the genu of the MCA. I know that pointing anteriorly means it can be either located close to the lesser wing, the sphenoid. So I have to be careful when I do the craniotomy. Okay, this is pointing anteriorly. Or I have to be careful when I open the dura. This is a tip of pars triangularis. Okay, the aneurysm is over here. So very careful, and the fundus is pointing towards us. So this is M1, the proximal control. And this is the aneurysm here, over here. All this is the aneurysm pointing toward the superficial part of a sylvian fissure. Very careful, okay? This is clipping. At the genu, pointing laterally or anteriorly. Laterally and anteriorly, so it is related to what? You see the lesser wing of sphenoid over here? Okay. You see? Very superficial, so be careful. And we have, you can play around with this kind of information for angiography, but you know, sometimes we're under heavy attack. One day you are the hunter, but the other day you can be hunted. So that is a problem. I'll show you a case. 43-year-old male, female, aphasia and subarachnoid hemorrhage on the third day, Glasgow Coma Scale 14. Severe subarachnoid hemorrhage and also hematoma inside the sylvian fissure. And this we have a very tiny aneurysm over here pointing a little bit downwards, a little bit laterally. Laterally means I'm in the sylvian fissure, and also hematoma in the sylvian fissure. Tells me that the fundus is pointing towards inside the sylvian fissure, okay? So someone under heavy attack, this is a very angry brain. This is on the left side. This is temporal lobe, frontal lobe. My resident is draining CSF, a little bit of CSF from the carotid system, and then we see the carotid artery for at least the proximal, the parent control. But I'm looking for the M1 to get the proximal control, and all of a sudden something starts to bleed. So samurai time. I know that very many young people, young neurosurgeons are watching us. So can I just present wonderful surgeries, and sometimes samurais can get attacked. And so we have to deal with this kind of situation. So I don't have, the only proximal control that I get is the carotid artery. But the first thing you have to see where is the rupture point. But you know, I was not expecting the aneurysm is located that superficially. So once you have to increase your suction power and be calm and find where the hole is, and try to remember the angiography is pointing laterally inside the sylvian fissure, and then what to do. And then you know that it is pointing laterally, and then you have identified the hole, and then be calm and try to deal with this kind of situation. Obviously, after clipping, stop the bleeding, you have to search if you have also clipped something else, not only just the fundus of aneurysm. You have to see if you have clipped, you know, the superior or inferior trunk. You have checked all these kind of things. Okay. So let's just so this is carotid artery. I go quick. First, we establish, then remove the clot and see the M1 for the proximal control. And then we go quickly to see the distal branches, the inferior trunk and superior trunk, and then the aneurysm, and see, fortunately, just clipped the aneurysm, and then this part remained. So we had to add another clip. So this is just to show the importance of knowing the anatomy and also knowing the angiography, and see what is the danger, where is the danger, how to build a strategy to get the proximal control to avoid the fundus of the aneurysm, to avoid the premature rupture. So it's been an honor to be with you, and I thank you so much for your attention. Thank you very much. Well, probably I am the moderator, so I have to keep going.
That was a great talk. Went beautiful, as always, so didactic. Always enjoyed, always learn something. I think next we have Mustafa, is that right?
Yes.
Dr. Baskaya?
Baskaya.
He's another true samurai. Mustafa, please.
Yeah.
Hello,
good evening, good morning, or wherever you are. Maybe good dreams, sweet dreams. So I'm going to share my screen. And thank you for having me, Juan, and your professors, Kobayashi, Matsushima, and the moderators, Professor Abe and Wen. Thank you. And I'm starting my talk on anterior cerebral aneurysms. I'm forever grateful to Dr. Rhoton. I wasn't his fellow. I didn't spend the time in his place, but in a way, he was my shokunin. I follow him like many of you guys did, and we learned a lot, and I'm very grateful to him and Professor Kobayashi and all his pupils carrying this his wisdom and legacy. So I have no disclosures, and this is our beautiful campus. And I found out September is the National Brain Aneurysm Awareness Month. So I saluted all the patients with the brain aneurysms or who suffered brain aneurysms. And Dr. Wan gave excellent lecture on anatomy. I'm not good anatomist, and many of these information is available, and everybody watching this webinar probably know more than I do. So I'm just going to jump, like Dr. Wen said, jump to the point and show you guys a few videos. Well, I think clipping in ACOM, anterior cerebral artery aneurysms, proximal ACOM or distal, to me is still gold standard because you permanently exclude the aneurysm from the circulation, and you have direct vision during the surgery. You have direct 100% control over the situation if you follow the principles of microsurgery set by our pioneers. You have the proximal distal control, and you can apply the clip, and you can confirm you completely obliterate the aneurysm by puncturing, cutting, or if you have angiography or other visualization techniques. How I approach to ACOM aneurysm, A1 aneurysm, just if it is unruptured, not very complex, no mass effect, I like to do terminal craniotomy. But if it is ruptured, swollen brain, high hand has great subarachnoid hemorrhage, I like to do modified OZ. And sometimes I combine with the, in some cases, anterior interhemispheric approach, but most of the time, terminal transsylvian. This is an example of A1 aneurysm case, young female, 48-year-old female with the left-sided decreased visual acuity and field defects, partially thrombosed, large aneurysm arising from the A1. And you can see the just part of it filling, and it's right at the distal part of the A1 before ACOM. And I just, wide arachnoid dissection is the key in these aneurysms. Sylvian fissure should be open in most, maybe all of the ACOM and this A1 aneurysms. It relaxes the brain, it separates the frontal lobe from the temporal lobe, and minimizes the retraction if you have to use retraction. And most of the time, retraction is just brief period of time. So we get the initial ICG to understand. And once I cannot do more, I put the clips here. I just jump it. I'm going to show you. I decompress the optic apparatus as much as I can. You see the Hübner artery here. And I am just mapping the live part of the aneurysm and staying away from it. So this thrombose part, and I'm opening the thrombose aneurysm. And I'm gonna using the sonopet, and it starts bleeding. That means temporary clipping wasn't perfect, and I put the pilot clip, and pilot clip allows me to get the more thrombus, but it's even in spite of pilot clip, now it starts bleeding from its base. So I'm replacing the pilot clip, taking the temporary clip, and I have good Doppler, proximal and distally. Now I can complete my thromboendarterectomy. You can see the avulse part and completing the dissection from the optic chiasm and optic apparatus. Now I have full anatomy, and I'm obtaining one more ICG green and completing the rest of the endarterectomy, thrombectomy. And once that's done, I can replace the clip more precisely and get the complete occlusion. So that's the way, and you don't want to be too ambitious with the neck clipping in some of the giant, and you see the Hübner, and last piece of the thrombus I took, and there's a fragile part of the neck you see looks very purple, and this I don't want to leave that, and I place a small micro clip there. And she woke up fine, and her visual deficits start improving right away and with the good angiography. So this is an example for A1 as proximal control, distal control, and in thrombosed giant aneurysm, you have to do thromboendarterectomy once you obtain the at least proximal control. And this is a 67-year-old Huntes grade 5 subarachnoid hemorrhage. To me, Huntes grade 5 subarachnoid hemorrhage almost like a patients with the GBMs. Nobody wants to do anything with them. I have a large series of grade 4s and the 5s, and I don't give up on these patients. And this is ACOM aneurysm means all perforators. Projection, anterior projection, no perforators, superior projection, posterior projection, inferior projection. You have to watch the perforators. Three main group of the perforators: chiasmatic, hypothalamic, and subcallosal, and they supply important memory and the important brain regions, especially the forniceal area and subcallosal area. And this is very tight brain, and ventriculostomy, yes. Large decompressive craniectomy, yes. And Sylvian fissure is 100% yes. You have to open Sylvian fissure in order to minimize the retraction and relax the brain. And in all ruptured ACOM aneurysms, whenever you can, you have to get the lamina terminalis. And opening the lamina terminalis significantly relaxes brain in most of these cases. And the no retraction so far, and the principles: go to the proximal control, first proximal control ICA, second proximal control A1, and follow the A1. And I just opened the lamina terminalis, suction the clot from the anterior third ventricle, and then next is going to the other side. Other side A1, that will allow us, and as said, like almost 13 aneurysm you should see when you are doing the ACOM aneurysm surgery. And A1s, A2s, Hübners, frontopolar arteries, and the perforators. So now I don't hesitate to take any gyrus rectus, ipsilateral gyrus rectus, that allows me to see the corner of the A1, A2 junction, as well as the ipsilateral A2. This aneurysm is anteriorly projecting, and one problem with anterior, they are okay to clip, relatively easier than the other projections, but they can be stuck to the optic apparatus. Early retraction can cause avulsion of the dome if it is attached to the optic apparatus, or sometimes even the planus sphenoidal tuberculum region. So this is anteriorly projecting. You see the ipsilateral A2, ipsilateral A1, Hübner, and you dissect Hübner well and detach, because with the traction you can avulse sometimes A2. I always get baseline ICG green, so I can compare. I'm putting the pilot clip, checking the Dopplers, checking the ICG green again, and this is pilot clip. I want to see the perforators, although they are away. I want to see the other A2, and everything looks okay, but I'm not happy because I'm not seeing the other side of it. I don't have the 360-degree exposure yet, so in order to do that, I'm puncturing. That's fine, it's not bleeding, but I have to mobilize, and sometimes bipolar modeling, sometimes cutting and bisecting the aneurysm helps you. I want to make sure the other side is okay, and the clip is completely crossing the neck. And I'm not happy, and since I'm not happy, I'm gonna end up cutting this aneurysm. Once you have full control, you can do that, but if you are at the beginning, you may be afraid of doing this, but after you watching the many people, you gain experience, you can do this. And sometimes we fail, but failures don't let us to fear all the time, right? We come back, we are samurais, correct? Dr. Morkos is watching me. I have to be very careful what I say about him. So, and it's nice clipping. Yes, we clipped it, but how is he gonna do, right? It's very long course, but eventually they do well. And my series of grade 4, 5s, MRSA score 0 to 2 in 1 year, 70%. It is very good results. So you can achieve it. don't give up on grade 4s, don't give up at grade 5s, okay? And solve grade 5s near 40%. So this is a grade 1, Hunt has 2 subarachnoid hemorrhage, suboptimally coiled at outside hospital. In this case, you see if ACOM is very short and there is no enough distance between both A2s, and there's no way you can dissect and create a space for perpendicular clip application, you have to do fenestrated clip across the neck, crashing the aneurysm. And that's not possible in sometimes with the current technology we have. You know, shortest clip available is 3 millimeter. Sugita or Yashargi clips, fenestrated straight or angle. So, and in this case, you can watch this video. Its segment was very short, and anytime I try to put 3 millimeter fenestrated clip, it is pinching this artery or pinching this ipsilateral or contralateral artery. So I learned this technique from my Nagoya days. I watched Professor Sugita. I was his last fellow, and he used to drill these clips, and I did it. And we have like 4 cases we had to drill the clip. It's good technique. Keep in your mind, keep in your surgical daily armamentarium. So this is another one. So coiling, right, is unruptured aneurysm. They coil it, and it ruptures several years after, 3 years after the coiling, it ruptures, and now it's grade 4 subarachnoid hemorrhage. And I mentioned you have to watch the 13 arteries, and this is the case. I don't want to take your time too much with these videos. Just try to be perfect with this clipping, okay? That's how coiling gain popularity, right? We were so afraid of doing the clipping, or we were just putting clipping and getting out. And that's not the way it should be. And we should follow the principle set by Professor Yashargil. Check every single time, and until you get the perfect, then you are done. And these fenestrated clips in superiorly and posteriorly projecting aneurysms they are lifesavers, straight angle, and you can crash, and you see the Hübner artery here. And temporary clip, utilize, don't use too often. If necessary, only use if it's necessary, and short breath of time, and always allow reperfusion between short clipping times. Again, grade 4 subarachnoid hemorrhage, previously coiled, and at this is 3 months. In 1 year, she started running marathon again. This is sometimes aneurysms are like this. There is no projection. Everything is blown segment of the ACOM. In these aneurysms, you have to be creative with multiple clip reconstruction strategies, and that's what we did here. And we got very good results. He's been aneurysm free almost 8 years now. Another one, be aware of the variations. ACOM, A1 is very, these are the common locations for the variations. And this is the variations infra-optic course. You see, this is the ipsilateral optic nerve, contralateral optic nerve. A1 is coming under the optic nerve. And it is not technically difficult, but if you don't aware of these variations and if you follow them, you can get in trouble. Another one, grade 5, and whoever treated at that time, okay, let's do the coiling, and if she survives, we'll see. And he survives, good coiling, but recurrence at 1 year, you can see. And these aneurysms, if possible, try your best to avoid taking the coils out. Be prepared for bypass. And if you have a good neck, you can crash some coils. And most of the time, these coils, you can see they are extraluminal. Ipsilateral A2, ipsilateral A1. I am crashing again. In this superior and posterior projection aneurysms, I love these fenestrating clips, and you can really crash, and you always watch hypothalamic perforators in this location and free them, dissect them, and protect them. Good results, and he did well. He was already he already made the good outcome. So this is a grade 4 ACOM aneurysm. Another example, and in this case, we use the cranioorbital approach. I'm going to the point, like Dr. Wen said, go to the point, dissect everything, do the lamina terminalis opening, and then find the aneurysm. You see the hypothalamic perforators, and this is the bolt dissector. I learned how to use this from Dr. Morkos, and going 360 degree if you can. If not, do your best exposure, get the neck, distal neck, proximal neck, put the clip, pilot clip, then see what you can do. If you are not happy and you have no flow, cut the aneurysm. You can cut it, no problem. And then that will allow you to see. So I'm putting another pilot clip on the top of that cut sac, and I'm replacing these and going for the perfect clipping, like my dear Japanese friends, colleagues do. They are perfectionists, artisan. They will do best. And that's how we should do. Real summarize. And good results, good outcome. What about this? This patient presented with seizures. Initially, they thought this is a meningioma. They do MRI and they realize this is a partially thrombosed giant aneurysm. It's very complex aneurysm in terms of complex anatomy. Understanding the anatomy is complex, but you see here, actually, I go to the thing. Here, this is actually left side pericallosal aneurysm right after the ACOM, and is very proximal, and is one afferent artery comes and other efferent artery goes. So there is no branching point here, but I love this partially, mostly thrombosed aneurysms because it allows you to debulk significantly. So you can really get chance to look around and then reconstruct. Our strategy, first reconstruction. I always go for reconstruction, but I'm prepared for A3 bypass if possible. If not, I prepare STA, and arm is also prepped and draped just in case if I need another graft. If A3 I cannot get it. And now I'm opening the aneurysm, and entire video, whole length of video, you can watch it. You go, and the exposure requires, in my opinion, required transsylvian and interhemispheric exposure. So we did a large craniotomy, and brain was quite swollen. We had to put the ventricle. So we start seeing the anatomy now. Proximal pericallosal, neck, and distal pericallosal. Once you get this anatomy, you can continue to get, you can continue debulking, thromboendarterectomy, or if you sense that you're gonna take less than 10 minutes, you can just put the temporary clips under motor evoked potential monitoring. And once you get that, try not to be very ambitious with the neck occlusion, because these thick wall aneurysm, you can occlude the orifice of the arteries. So just initially do your best, get the temporary clips out, inspect, and then you can perfect your thing, and even you can suture like we did here after removing some of the clips. So, and he did very well. As you can see, we left the base here, and that's all you need to. And he's been doing very well last 4 years. And this is a very complex case, 10-year-old with headaches, partially thrombosed pericallosal aneurysm from the left, and you see is fusiform, partially thrombosed, very ugly shape, and this is proximal pericallosal and very small pericallosal. And there's no way you can deal with this endovascular means. So you have to do some kind of surgery. And how? A3 bypass, then trapping, or just simple trapping. And, or if A3 is not enough, and you see this branch is quite small and there's a big space, if you cannot free and bring them together, you can do jump graft from ipsilateral STA to A3, then trap. But first, you look at all the collaterals. There's no good posterior pericallosal collaterals. So even though it looks that way, I always do ICG green, put the clip. If there's no simultaneous filling, simple trapping is not going to work. You're going to give this 10-year-old distal ACA infarct. And we opened the sylvian fissure, we opened the proximal. First, I am looking for the both arteries, and there is no way you can bring this. I dissected, eventually decide A3 is not possible. And I put the temporary clip, ICG green. See, it's not filling simultaneously. So that means you cannot simply trap this. Opening the sylvian fissure, going for the proximal control, and now the plastic surgery team start harvesting the radial artery, and I already dissected the STA branches and radial artery here, and soon we realize there's a big hole in the radial artery, and we repair that. And radial artery we measure, we did the preoperative MR angiogram of the arm, everything, and still it was short, turned out to be short. Although initially we measured 18 centimeter we need. And this is very narrow space, doing the proximal bypass first, distal bypass first, A3 to radial artery bypass, nice backfilling. Then, since it's short, I have to go for the frontal branch, and frontal branch, there's a big size mismatch. I'm using the tapering technique. This is we published before. So if you have a tape, you cut obliquely and bring together. And bring that. It's small, still mismatch, but there's no other option other than using saphenous vein, and that's we already done the distal bypass. Taking nice filling, and look at this, all filling nicely. A3, postoperative day 3, postoperative 2 months, radial artery counts A3, and he's back to school. So I think I'm taking too much time, but also I told you guys, don't give up anytime in any aneurysm surgery. Huntes grade 3 subarachnoid hemorrhage, distal ACA. What I planned that this is left side pericallosal, crossing the right side, but just exposing the interhemispheric fissure, not just true bifrontal craniotomy. And we prepare for that. Patient had the ventriculostomy that night in the morning, electively, and I was washing my hands. Chief resident called me immediately, coming out, said that ICPs is 100, frank blood is coming from the external drain, her blood pressure is low, bradycardic, and she's dying basically. So suddenly I turned this small interhemispheric approach to a large bifrontal craniotomy, and his dura is so stuck. I did one side, you see the brain herniating from the right frontal side, and then we gave adenosine to stop the bleeding. It's constantly, she's bleeding from the ventriculostomy, and I went for the right side, although initially I planned going to left interhemispheric. I am doing the temporal frontal polectomy, lobectomy, and once I get done, brain is controlled to ICPs, I go to the lateral ventricle, okay? Go to the lateral ventricle first, that decompress, that I know there's still bleeding from here. And every time I try to suction, and the blood is coming. But at least we stabilized the ICPs, then we went for the proximal control, we found the proximal control, and we didn't give up. And finally clipped the aneurysm, and this aneurysm was constantly bleeding during the exposure. But once you get the proximal control, everybody relaxed, patient is stable, we gave her a pentobarb, and now there's no active bleeding until I cause the bleeding. And I'm moving with my temporary clip from very proximal to distal, so diminishing the ischemic area. And again, I got the re-rupture again while I'm dissecting, but I have full control. This is not a problem. And I coagulate the dome, separate it, and now I can get the aneurysm. Neck is done. neck is exposed, you can get the very good clipping, remove the temporary clips, and this is the final appearance. And everybody want to give up on her. This is the cranioplasty after a few weeks. So, and believe or not, 6 months MRSA score 2, 15 months MRSA score is 0. And she's living normal. She was gonna die. If she was in the operating room, if she didn't rupture, if she ruptured on the way to operating room, she would have died. But we didn't give up. So never give up on the brain aneurysms, okay? And go to the lab. Always go to the lab. Anatomy is everything. And wide dissection. Don't get stuck with the keyhole surgery, pinhole surgery. I go to the clip the aneurysm from the eye. Do the best for you, for that patient, okay? Wide arachnoid dissection, proximal, distal control, 360 if you can expose, then perfect clipping. Don't waste your time with the terminology and those coining the terms, okay? Anatomy is everything, and this meeting is all about anatomy. Read, listen, watch, dissect. I hear, I forget. I see, I remember. I do, I understand. Thank you for your time. I always exit my time, and sorry, I apologize.
Thanks, Mustafa. That was really something. I think if you believe in miracles, they actually may happen, as it was in that case. Pretty spectacular.
Thank you.
Jacques, do you want to make any comments?
Mustafa, very proud of you. You outdo yourself every time. I love the passion. I love the skill, and that's it. Congratulations.
Thank you. Thank you.
Mustafa. Hiroshi, would you introduce our next speaker for us, Dr. Hongo?
Let's move to next presentation. Next presenter is Dr. Hongo. He's a honorary professor of Shinshu University. Now he belongs to Inner Central Hospital as director of hospital. So please start the presentation, Dr. Hongo.
Hello, can you hear me?
Yes.
Okay. Good evening and good morning from Japan. Well, it's a great honor for me to present in the great session symposium. Well, this is my hospital. I'm currently working. I'm enjoying my place. My title today is Anatomy and Surgery for Basilar Bifurcation Aneurysm. Well, nothing to disclose. Well, basilar bifurcation aneurysm, its incidence is about 6.6%, not much, including basilar SC aneurysm as from UCAS Japan. Well, an anatomical issue from surgical point of view, the basilar bifurcation is deep and narrow, and there are many perforating arteries. So technically, among the most difficult aneurysm to occlude. Well, basilar bifurcation aneurysm current treatment modalities are basically coiling. Clipping is getting less and less, but still clipping technique remains quite important though. Here, of course, Rhoton has a textbook. In his textbook, here's the drawing about basilar bifurcation. There are various patterns of perforating arteries we need to preserve during clipping surgery. Here is the schematic drawing by my senior colleague, Dr. Gibo. He's also one of the Rhoton Fellow. He published a textbook for medical student and resident. He also showing the perforating arteries at the basilar bifurcation. Well, I can say here is the three giant pioneers for basilar bifurcation aneurysm clipping. Dr. Blake, Yashijil, and Professor Sugita. Well, Dr. Blake published his aneurysm clipping of the basal artery back 1961 for ruptured aneurysm through the subtemporal approach. Here is the drawing. And then Professor Yashijil, he published his papers of basal bifurcation aneurysm. He mainly used tyranno approach. Here's the drawing he in his paper from the tyranno is optic nerve and the internal carotid artery. Here is the aneurysm here also. And then Professor Sugita, he published basal artery aneurysm in 1979 when he was in Shinshu University. He preferred approaching the basilar bifurcation aneurysm through tyranno approach. This curved triangle is the root in the tyranno approach. Well, regarding surgical approaches, basically there are two, tyranno and subtemporal approach. Regarding temporal approach, here is the very famous Professor Sugita's atlas, Microneurosurgical atlas. In this atlas, there are various cases introduced on basal bifurcation aneurysm. I'd like to introduce some. And also here, Professor Kobayashi, he published a great book, Neurosurgery of Complex Tumors and Vascular Lesions. These two are my mentors. Unfortunately, my name is here with Professor Tugwell. And illustration drawn by Dr. Nita, also my colleague. In this textbook, there is one section regarding basilar bifurcation aneurysm. And I also like to show some illustration and description. Tyranno approach, Professor Sugita and Kobayashi proposed basically three approaches from three routes: optical carotid route here and spular bifurcation route and retrocarotid route lateral to the internal carotid artery. Here is the posterior communicating artery, lateral or medial approach. There are two of this retrocarotid route. And here is the drawing atlas by Professor Sugita. Here is the basal bifurcation aneurysm approached with optical carotid route. Here is right side optic nerve and internal carotid artery. Between the two is the aneurysm and crypt with this route. And here also optical carotid route, a rather large aneurysm. So once clipped and with also with P1 and punctured and repositioned and nicely clipped with optical carotid space route. And here is the route from the medial retrocarotid space. Here is the internal right side internal carotid artery and posterior communicating artery. This aneurysm is not possible to occlude with gripping, just exposed. And here is the case lateral to medial retrocarotid space. Initially exposed or exposure was done from the lateral retrocarotid route, and then application of the clip was done through the medial retrocarotid route. Here is the pulsating arteries from the posterior communicating artery, lateral retrocarotid route. This is a case exposed and clipped with from the lateral retrocarotid route. And this is a case going through lateral retrocarotid route. The clipping was done with the fenestrated clip from lateral and medial to the posterior communicating artery. This is also a case of lateral cut root, but the clipping was not attempted. And here, not many cases, but we have some cases of spular bifurcation root is good, like short internal carotid artery. In this type of case, spular bifurcation root is preferable. And another basic approach is subtemporal approach. Here is the case. Look here, the aneurysm is low position aneurysm. In this case, this is the case Professor Kobayashi did and his drawing. So this low position aneurysm, subtemporal approach is preferable to expose the proximal basilar artery trunk, the so-called Cause's triangle was partially removed from the intradural space, and clipping was attempted and succeeded, here showing post-operative angio. Well, here showing the characteristics of tyranno and subtemporal approaches. For low positioned, subtemporal approach is better. Temporal retraction is, however, much in a subtemporal approach. The proximal control of basilar artery trunk is not quite difficult, subtemporal, but rather difficult for tyranno approach. And contralateral P1 is easily quite visible in tyranno, but difficult in subtemporal approach. Perforating preservation is very important. Sometimes it's quite difficult for tyranno approach, especially when the aneurysm is vented posteriorly. But subtemporal approach is rather easy, and oculomotor nerve is in the way in subtemporal approach. So there are factors to be considered for selecting approach: height, position of the aneurysm neck, and a projection of the aneurysm dome, and size, of course, needed to be considered. Well, here is the one modification, temporal approach we considered. With this approach, we can get a rather wide space, but in this approach, bridging vein need to be sacrificed. So indication is quite limited. So application of tyranno approach, we can say extended tyranno approach, orbitozygomatic approach, and transcavernous approach. These three approaches are applied tyranno approach. Here is the schema. When the aneurysm is upperly located, the osteotomy is applicable, but how about lower position? Well, subtemporal approach is one thing, but the posterior client removal or transcavernous approach is applicable for lower position aneurysm. This is the case I published in Techniques in Neurosurgery many years ago, including basilar superior cerebral aneurysm. Here is drawing anterior client process and also posterior client process to see the aneurysm from the tyranno approach. Here is the drawing removing anterior client process and posterior client. Then clipping was possible. This is post-op angio. This is drawing. This is not the basilar bifurcation, but the superior cerebral artery, but the concept is quite the same. Here showing the post-op angio. Now, I'd like to show just two cases I did for basilar bifurcation aneurysm. It's unruptured aneurysm through the right tyranno approach. Eventually, optical carotid approach, because internal carotid artery is rather long, redundant, and there is a wider space here between optic nerve and internal carotid artery. Here, carrying the arachnoid, and from this route, we can see the here is the aneurysm basal bifurcation, right P1 and left P1 arteries branches. And with this space, the clipping was attempted. Yeah, from this space, I can control the proximal basilar artery trunk. Yeah, here after clipping, the completeness of the clipping was confirmed. Well, here is the next case, 71-year-old woman, unruptured as this aneurysm. A little bit wide, so endovascular team in an institute hesitated to do, but currently it is possible to do endovascular, but at this time I did direct clipping with a right subtemporal approach here. And this is the operative view. In a way, there is the right oculomotor nerve. And here is the right SCA and P1. And here is the PCON, posterior communicating artery is short, and aneurysm is hidden under this. And so first I separated the perforating arteries from the dome, but the whole aneurysm neck is not visible. So here, preservation of perforating arteries. And here, posterior crinoid is also interfering with the operative field and short posterior communicating artery. So I decided to occlude and cut the posterior communicating artery just posterior to the perforating arteries, and posterior crinoid is being built to see the aneurysm neck here, and confirming the perforating arteries on the contralateral side, and place a temporary clip to the basilar artery trunk as proximal control, and then dissection the neck of the aneurysm to make space for aneurysm clip, and gently occlude the aneurysm neck, seeing the preserving the perforating artery, confirming the preservation of perforating arteries this side and also the contralateral side. And gently, and the aneurysm was safely clipped, and temporary clip was removed. And here showing the postoperative CT, and the patient has another associated aneurysm also clipped. Well, this is my conclusion. Anatomy and surgical approaches of the basilar bifurcation aneurysm were presented. And my take-home message is knowledge of the anatomy of the basilar bifurcation area is essential for clipping surgery. Even in the era of the endovascular surgery, clipping techniques are needed to be handed down. Here is the doctors collaborated from from Shinshu University regarding this field of pathology. Professor Sugita, Kobayashi, and so forth. Thank you very much for your kind attention.
Okay.
Wonderful lecture. Hiroshi, you are next.
Okay.
Hiroshi Abe is, a dear friend of mine, and we worked together in Rhoton's lab for 2 years, and since then we've kept our friendship. And that's one of the joy of working in the lab and meeting people from everywhere in the world. He's also an accomplished guitarist, although he doesn't want to say it.
No.
So please, Hiroshi.
Okay. Okay, thank you very much, Fang. I'd like to talk about the anatomy of the cerebromedullary fissure, focus on the cerebral vascular disease. So cerebellum has three surfaces and three cerebral brainstem fissures. So today's focus is cerebromedullary fissure. This fissure is the deepest fissure in the three fissure. So cerebromedullary fissure running is a pica. So cerebral fissure anatomy is very close relation to pica anatomy. So cerebromedullary fissure is the roof of the cerebromedullary fissure is formed by the tonsil and the biventral lobe and uvula, and the floor is formed by the terra colloidea and inferior medullary velum and medulla oblongata. So this is a cerebral junction between the inferior medullary velum and the terra colloidea. So upper limit and the lateral limit of the cerebromedullary fissure is a lateral recess and the foramen of Luschka. So this is a lateral recess. Here is the upper limit of the cerebromedullary fissure, and this is foramen of Luschka as a lateral limit of the cerebromedullary fissure. So cerebromedullary fissure, including some part of the pica. So pica have a 5 segment. So tonsillomedullary segment and cerebrotonsillar segment causing inside of the cerebromedullary fissure. So this is after opening the cerebromedullary fissure. This is tonsillomedullary segment causing upward to the cerebromedullary fissure, and this is cerebrotonsillar segment very near to the lateral recess, upper end of the cerebromedullary fissure. So this is a distal pica aneurysm case. Aneurysm located very near to the lateral recess, near to the cochlear nucleus. So after widely opening the cerebromedullary fissure, we can identify the aneurysm located upper side of the cerebromedullary fissure. So transcerebral fissure approach is reported by the Professor Matsushima in 1992. So this is separated the extensive type and the lateral wall type and the lateral recess type. So cerebral approach is reported by Dr. Mushi. So this is very similar approach using the cerebral junction. So cerebromedullary fissure, transcerebromedullary fissure approach is a 2 pattern. If we should access to the pica, we don't need to remove the terra colloidea. If we need to enter the fourth ventricle, we need remove to the terra colloidea. So after opening the cerebromedullary fissure, cerebellum should not retract upward. So, cerebellum should be retracted dorsal projections. After opening the cerebromedullary fissure, cut the tinea along the cut the terra colloidea along the tinea. So just like this, and to the go laterally, lower edge of the lateral recess. So I'd like to show the one brainstem lesion case. So she's a 33 years female. The cavernoma located dorsal part of the upper pons. So she has a bilateral MLF syndrome and severe truncal ataxia and right facial palsy. Modified ranking scale is 4. So I choose, this is Dr. Fernandez Miranda's paper. According to this paper, and I choose suprafacial approach here. So this is transcerebral medullary fissure and suprafacial approach for the cavernoma. The opening cerebral fissure, this is terracoloidea, and cut the terracoloidea along the tinea. So, and this is left side, and also right side cuts the tinea. This is a lateral recess. This is a foramen brusca, lateral end of the cerebral medullary fissure. So this is a rhomboid lip. So after opening the widely cerebral medullary fissure, we can identify the floor of the fourth ventricle. This is a stereo medullaris, and identify the facial colliculus using facial nerve stimulator. So we can identify the facial colliculus here. So by marking the facial colliculus, and this is a suprafacial area. So we can cut here. So after entering into the cavity of the hematoma, we can dissect the cavernoma. So we should keep the gluteus layer of the brainstem to avoid the brainstem damage. So this is a gluteus layer, and this is a cavernoma. So after remove cavernoma, this is final view. So this patient symptoms are improved, and finally he come back to her daily normal activity. So this is not a cerebrovascular disease, but this is a good case for introduce the pica anatomy. So this is 8 years old male, a boy, medulloblastoma in the inferior vermis. So cerebral medullary fissure is very useful to avoid the vermis, damage of the vermis, and this is tonsil and uvula, and we can open the uvula tonsillar space, and after widely opening the cerebral medullary fissure, we can cut the inferior part of the vermis uvula. So remove the tumor, and this is hypervascular mass. So opening the cerebral medullary fissure laterally, we can identify the pica, and this is a feeding artery of the tumor. So after widely opening the cerebral medullary fissure, we can identify the feeding arteries arising from pica. So this is a feeding artery going to tumor. This is the main trunk of the pica. So we can cut the feeding artery safely, and after cut the feeding arteries, very easy to control the bleeding. So this is a good way to perform the complete removal of the tumor. So patient has no neural deficit, and the patient receives chemotherapy and radiation therapy. So I'd like to show some pica revascularization cases. Pica has many variations. It's just like this. Pica causing just above the tonsil and causing upper part of the cerebral fissure and causing below the tonsil. So they have many variations. So this case has the ruptured VA pica aneurysm, pica arising from aneurysm. So, and this patient has a low position caudal loop, so just like this pattern. So we don't need open the cerebral fissure to anastomosis here. So we just do a lateral suboccipital craniotomy and transcondylar fossa drilling for approach to the aneurysm. This aneurysm located anterior surface of the medulla. So this is the left side transcondylar fossa approach, and this is the drilling of the condylar fossa, and so drill to the near to the, this is eminence is jugular tubercle. So after drilling the jugular tubercle partially, we open the dura, and the pica located below the tonsil. So this case is no need to open the cerebromedullary fissure to make a bypass. And this is aneurysm located in front of the medulla. So this is very easy to do anastomosis in this case. So preparating the occipital artery, and no need to retract the brain. So very little bit deep, but it's not narrow operative field. We can safely do the anastomosis. So this rubber sheet is made by Dr. Kamiyama and Tanigawa. This is good for the bypass. So after bypass, we can clip the aneurysm through the transcondylar fossa craniotomy. So watertight dural closure is needed to avoid the CSF leakage. So we use muscle pieces and fibrin glue. Post-operative shows good drilling near to the jugular tubercle and OA bypass performed here. And the next case is left VA pica partially thrombosed large aneurysm. Medulla is compressed by the thrombosed aneurysm, and this patient has very high position pica here. So this is the upper part of the cerebromedullary fissure, just like this. So in this case, we have to open the cerebromedullary fissure to make a OA pica bypass. This is aneurysm, and after opening the cerebromedullary fissure, we can identify the pica. And after OA pica bypass, we can trap the aneurysm, clip the distal part of the VA and the proximal part of the VA, preserving the perforating arteries, and clip the proximal part of the pica. And then open the aneurysm and partially remove the thrombus using sonopate. And we should not touch the adhered part to the medulla. So we finish the partial thrombectomy. This is 6 now. So after operation, a patient has good course, and partial thrombosed aneurysms are the shrinkage. This is also another case, dissecting aneurysm of the pica. At first, I planned to anastomosis here, but caudal loop is dissected, so we cannot use as a recipient artery. So after opening the cerebromedullary fissure widely, we can identify the cranial loop here. So we can do the anastomosis at the cranial loop. So this is another case, a ruptured VA pica aneurysm. This case has no caudal loop. So this is a very high cost in the cerebral upper part. This pica located upper part in the cerebromedullary fissure. So after widely open, we can access to the high position of the pica. So according to my personal experience of the 42 OA pica bypass cases, low position pica is only 28%. Majority, 43% has a high position pica. At that case, transcerebral medullary fish approach provides a sufficient operative field for bypass. So, thank you very much. I really appreciate to Dr. Rhoton and Dr. Fan. Thank you very much.
Thanks, Hiroshi. Beautiful lecture. As always, amazing pica bypass. So please, Hiroshi, go ahead and introduce Rokuya.
Okay. Next presenter is Dr. Tanikawa, very famous neurosurgeon. He's a real samurai in Japan. So he belongs to Teishinkai Hospital at Sapporo. This is a northeast part of Japan. So please start the presentation, Dr. Tanikawa.
Can you hear me?
Yes, yes.
Thank you very much for inviting me to such a wonderful meeting. Thank you, Juan. It's a great honor for me. My disclosure is like this. Today, I'd like to talk about the cavernous anatomy and transcavernous approach to a posterior fossa aneurysm. The landmark of cavernous anatomy is like this: meningoopter band, supraorbital fissure, 3-4 V1 and 6 nerve, and lateral and medial edge of anticlinal process. We can understand the proximal ring and the distal ring. This structure is Hoyer. Hoyer is this structure, and foramen rotundum, which has a V2 of the trigeminal, and the anterolateral triangle, foramen ovale, V3, and we should understand the lateral loop, and the foramen spinosum for middle meningeal artery and the venous sinus, and the Glasgow and the Kawase's triangle. This is a picture from Professor Fukushima's textbook. This is a very famous picture in the anatomy of cavernous sinus. And this is an illustration drawn by my colleague, Cosmo Noda. He do very well the middle fossa dissection like this. We can recognize the Glasgow triangle right here. And medial to GSPN, we can find the Kawase triangle. This is a very important anatomy to understand the middle fossa anatomy. But first, I'll show you a brief description of the anticlinal. This is a CT angio upward view to see the anticlinal process. Here's the apex, and the medial edge of the anticlinal process indicates the distal ring is right here, and the lateral edge of the process indicates the proximal ring. And this is the actual view of intraoperative finding after elevating dura propria from a supraorbital fissure exposing anticlinal process lateral edge, and the V1 and the V2 foramen rotundum right here, and the oculomotor should be here. And after anticlinodectomy, we can skeletonize the optic nerve by skeletonizing the optic roof and anticlinal, making the hole inside anticlinal process. And after taking out the anticlinal process, we can open the optic sheath to decompress the optic nerve if optic nerve is elevated by the big annual something. And cystolic carotid can be secured, and you can find the proximal ring right here, and the distal dural ring is just part of inferior wall of optic sheath. I'll show you an actual case of anticrinodectomy, 66-year-old right side ophthalmic aneurysm, small one. This is a right front temporal craniotomy. After the craniotomy, you can straighten the orbital orbit like this, and then you can inside the supraorbital fissure. And with a meticulous hemostasis and exposing the cavernous lateral wall, you can recognize the V1s. By cutting the main orbital band, you can expose the lateral edge of anticrinal process. Then we can go to a drawing of anticrinal process, making a hollow inside of anticrinal process and exposing the optic nerve. And gradually, you can scrutinize the C3 carotid, recognizing oculomotor nerve and the proximal ring. Then a tip of anticrinal process could be detached from the siphon of the internal carotid artery. And by incising the frontal dura toward the optic sheath, you can find the distal dura ring is attaching at C3-C2 junction. By opening the carotid oculomotor membrane like this, we have a venous breathing from a cavernous sinus. You can get a control with a sagittal or gel form like this. Then you can open the optic sheath. Now we can expose the C2 proximal segment, exposing ophthalmic artery. And medial to ophthalmic artery, I am confirming the distal dura ring medial part. Then here, this is the remaining optic strap. Just under the optic ophthalmic artery, the superior part of distal dura ring can be inside towards medial part of distal dura ring. Now, almost preparation could be done. Then you can approach to the aneurysm. The tiny aneurysm at the ophthalmic origin could be found. To be honest, I couldn't realize in the preoperative angiogram. Anyway, this is a remaining flap of the distal dura ring. This can be detached from the carotid wall with a sharp dissection. And now we can confirm the anatomy, distal dura ring, proximal ring. The relationship of anatomy is very important. Then I am trying to do a test temporal clipping of the C3 carotid. And then reduce the tension of the aneurysm. You can perform the neck clipping safely. And additionally, tiny aneurysm, ophthalmic aneurysm could be clipped. This is anticrinoidectomy and paracrinoid aneurysm clipping. Post-operatively, nothing happened. Next, I'll show you a transcavernous approach to a basal aneurysm. We can extend the retrocarotid triangle inferiorly, mainly in the transcavernous approach. Lower limit of this approach is ICA. And we can mobilize the oculomotor nerve by releasing oculomotor foramen and by freeing cavernous segment of oculomotor nerve. This is a drawing of the transcavernous approach drawn by my colleague Cosimo Noda. In this approach, we can confirm all these important landmarks. Especially in this approach, we can free the oculomotor cavernous segment, the oculomotor foramen, and then we can mobilize the oculomotor nerve to reduce adding tension during manipulation of the aneurysm, and we can prevent the oculomotor nerve palsy. I'll show you an actual case. This is the thrombosed giant basal SCA aneurysm, symptomatic. Patient came to me with ataxia and oculomotor nerve palsy. In this case, I have already prepare the superficial temporal artery to do a STA P2 bypass. In case of accidental PCA occlusion after neck clipping something. And this is the transsylvian root, antetemporal root. I am confirming the origin of and neck of aneurysm and contralateral P1. And this is the ipsilateral supracerebral artery. And contralateral P1 is occluded. Basilar trunk is occluded under the oculomotor nerve. And this is the right P2. And now I am dissecting distal neck between P1 and aneurysm. And there I could make the space to put the clip at the neck. And after detaching, removing the temporal clip, the supracerebral artery was occluded by the first clip on the neck. So I put the second clip distal to the first clip. Then I could get a patency of supracerebral artery. But unfortunately, the Doppler sound of supracerebral artery was a bit weak before neck clipping. So I decided to perform the additional supracerebral artery bypass through the transsylvian root like this. Just above the ocular, just inferior to oculomotor nerve. IC green shows a very good patency of both bypass and a good obliteration of aneurysm. Fortunately, this patient, nothing happened, no ischemic complications, discharged well. Next case, 77-year-old female, right side basilar SCA aneurysm. Right P1 is very hypoplastic. This is the right front temporal craniotomy, optical skeletonization. Then I open the dura and I am trying to separate the sylvian tissue from distally to proximal. Now I am exposing an MCA bifurcation of the M2 segment, and I am approaching to a carotid system. This is an internal carotid artery C1 segment, C1 and temporal uncus. You can see it, and the corridor artery was detached from temporal uncus, and that is the origin of PCOM. And the cisternal segment of oculomotor nerve is coming into a cavernous sinus, and this is a temporal uncus, which was attached to oculomotor and the veins. And now I am opening the ambient system, entry of the ambient system. Now P2A and PCOM is exposed. Here, at this moment, we can confirm the aneurysm just under the oculomotor nerve. Very small P1 is just distal to the aneurysm. This is a contralateral P1. Contralateral oculomotor just below the contralateral P1. And I am confirming the distal neck because there is a small perforating arteries arising from very proximal of a tiny P1. I am dissecting the connective tissue between aneurysm and the tiny perforator. Now I am securing the basilar trunk to put the temporal clip. But the operative field was too narrow to clip the aneurysm, so I decided to extend the operative field to perform the transcavernous approach. Now, the dura propria is elevated, oculomotor nerve foramen is open, cavernous segment of oculomotor nerve is detached from cavernous sinus wall. Then we could make the sufficient space to put the temporal clip to a basilar trunk. And I'm trying to do a neck clipping, not to occlude the very tiny perforator at the ipsilateral P1 and the perforators just behind the aneurysm. I am confirming whether no perforator is bite or not. Unfortunately, the small perforator behind the aneurysm is occluded by the first clip, so I am a bit pull out the tip of the blade to maintain the patency of the tiny perforator behind the aneurysm. Now, with very highest magnification, you can confirm the patency of a small perforator like this. This is very important. To see with the highest magnification, we need a sufficient bloodless operative field. So the transcavernous approach for such a situation was very effective to achieve the satisfied result. And the icy green shows a good preservation of all the important vessels, ipsilateral P1, tiny perforators behind the aneurysm like this, and of course, basilar trunk, supracerebral, everything could be preserved. Now, the open cavernous segment oculomotor nerve is covered by a dura propria, and close the dura propria not to squeeze the oculomotor nerve. Now, the CT angio shows a good patency of the basal trunk and the PCA and the SCA, and no high signal appears after surgery in diffusion image. This is another case, 55-year-old unruptured ICA aneurysm. This is a right side approach. Already the dura propria is elevated, anterolateral triangle is exposed, and the antecrine process is exposed. And you can confirm the cisternal segment of oculomotor and the fourth nerve. Between third and the fourth, the lyricus membrane could be inside and the supracerebral artery is exposed. And the thick lyricus membrane is cut. And I am extending the operative field by incising the dura marca between the third and the fourth, and partially open the cavernous sinus, and oculomotor is free. And then I could put the temporal clip to a basal trunk, proximal basal trunk, and aneurysm treatment could be done safely. Icy green shows a good preservation of ICA. This is a final view, and the CT angio shows a good obliteration of aneurysm. This is a 72-year-old female, basal top aneurysm. The relatively high position. The post-term perforating artery is attaching so much to the right side aneurysm dome. It could be recognized on the CT angio. In this case, I performed the epidural transcavernous approach by exposing a third, fourth, and a V1. And in the subdural space, I could retract the temporal uncus posteriorly like this. And now I am securing a retrohaltile space. Now the aneurysm could be exposed. The right temporal posterior term perforating is stretched, attaching on the dome, and the cavernous segment of oculomotor nerve is free. And adult type PCOM should be cut in this case, not to injure during the manipulation of aneurysm. Now you can put the temporal clip to a basal trunk, and I am trying to detach the posterior term perforating artery on the neck to make the space to put the clip on the neck. The contralateral P1 and the SCA is occluded, and still I am trying to detach the post-term perforating artery from the dome. The adhesion was very strong. At this moment, after 15 minutes of temporary clipper to the basilar, MEP disappeared. So I deflowed the basilar artery again. And 15 minutes later, again, I tried to occlude the basilar artery. And the contralateral P1 and SCA is occluded, and ipsilateral SCA is occluded. Only ipsilateral P1 is open, and after the dissection of the perforator, I could make the space to put the clip, and I am trying to pull the aneurysm. In this case, I am pulling the aneurysm dome by microforceps, not to escape the aneurysm during clipping. And the icy green shows all the preservation of the perforators. The CT angio and the MRI scan shows a good condition of the brain. Finally, in the last, I'll show you middle fossa anatomy. This is a middle fossa elevation. And we must understand this anatomy, the Glasscock triangle, definition of Glasscock and Kawase's triangle, and temporal rhomboid, V3, GSPN, arcuate eminence, P plus H. The temporal rhomboid is very important, and the IAC should be skeletonized at the 60 degree in each side. And after during the temporal rhomboid exposing internal auditory canal, we can recognize this anatomy. This is a very important anatomy. In anterior petrosectomy, temporal rhomboid during, we can secure the operative field between B3 and 7 and 8 complex. In the middle fossa skull-based anatomy, this is not the aneurysm case, but this is a good example to understand the middle fossa anatomy. This is the left side frontotemporal parietal deep craniotomy to do a cholesteatoma in the middle ear. After the complete hemostasis, visual space, this is the orbital skeletonization to expose the supraorbital fissure to elevate the dura propria. And I am confirming the foramen rotundum supraorbital fissure. Dura propria is elevated from cavernous sinus gradually. And this is the foramen spinosum, the middle meningeal and the middle meningeal sinus is coagulated and cut. And you can recognize foramen ovale, the V3 is right there. The spinosum is packed with the bone wax. And here, this is the foramen ovale. The dura propria can be incised. And between V3 and V2, you can expose the lateral root. The venous bleeding comes, always venous bleeding comes from cavernous, post-cavernous. We need to get a complete hemostasis in every step. Gradually, you can elevate the middle fossa dura. The oozing from detached exposed bone is very messy. So the complete hemostasis is necessary. And here is a lesser petrosal nerve, which was originated from a genital ganglion. As well, here is a GSPN. You can find it with a nerve stimulator, with getting the response of a facial nerve. And GSPN could be preserved by a gentle elevation of a dura propria in order to expose the temporal rhomboid medial to a GSPN. Simultaneously, you can expose the posterior border of a V3. Now, the temporal rhomboid could be exposed. Lesser and the GSPN could be exposed. And then we can recognize here is the temporal rhomboid after elevation of the middle procedure. Between a lesser and the GSPN, you can find a C6 carotid covered by very thin bone. Here, this is the temporal rhomboid, P plus H, posterior border of B3, GSPN, and arc-8MS. These landmarks makes the temporal rhomboid. Then anteromedial corner can be a start point of a temporal rhomboid during, because just under the GSPN, there is a C6 internal carotid. So that we have to be careful not to injure the C6 carotid during a temporal rhomboidectomy. In conclusion, bloodless exposure, complete hemostasis in every step is important. Comprehension of cavernous anatomy. We need to understand all the landmarks. For example, anticavernous, in cavernous, optic nerve, anticrinal process, optic slat, oculomotor membrane, oculomotor membrane, proximal ring, distal ring, diaphragm cell, oculomotor foramen, posterior crinal process, trochlear foramen, meningoopter band, supraorbital fissure, foramen rotundum. In the posterior cavernous, we need to understand the foramen ovalis, spinosum, GSPN, internal carotid C6, median nerve, median canal, genital ganglion, base articular nerve, posterior border of V3, Meckel case, Meckel tape, P plus H, internal auditory canal, cochlea, trigeminal, and petrosphenoid ligament. These are the very important anatomy to understand. That's all. Thank you for your attention.
Thanks, Rokuya, Dr. Tanikawa. That's a great lecture. We're looking forward to hear more from you in the days to come. Thanks very much for joining us and showing your mastery.
Yeah, thank you.
And to finish today's session, which I think has been great, we still have about 500 attendees following us. So thank you all for staying with us. I want to introduce someone that doesn't need an introduction, which is Dr. Gary Steinberg. He's been the chairman here at Stanford for 24 years, and he's now stepping to a next stage. I'm sure he's very happy about that. I'm personally very grateful to him for recruiting me to Stanford, which has been an honor and a privilege. And Dr. Steinberg, he's not only a true master of vascular neurosurgery, but also a very innovative neurosurgeon and creative. So I asked him to share with us some of his innovations. So Gary, thank you so much for joining us.
Great, thanks so much, Juan, for inviting me to talk. Can you hear me okay?
Yes.
And you can see my slides?
Yep.
Great, excellent. So, and thank you all 460 who are still watching this for sticking it out for the last few hours. I've really enjoyed the prior speakers. So Al Rhoton, as we've all expressed, was a true giant and a mentor to all of us. But besides being a master of surgical anatomy, a really creative surgeon himself, a superb educator, and a builder of one of the best departments of neurosurgery in the country, he was also an inventor. When I spent a year as a fellow with Charlie Drake, I discovered Charlie always asking for what he called my little thing, and that was a Rhoton number 6. And I asked him, why do you use that? He says, because it's a great dissector and the size of the tip is exactly the size of a Sagita aneurysm clip that I can fit into small spaces. And as the residents and fellows here at Stanford know, this is my favorite dissecting instrument as well. Here are my disclosures. When I trained, of course, we didn't operate in the brainstem, thalamus, or basal ganglia because it was too high-priced real estate. But over the years, we do now operate there, and I'll show you some of the examples of that. And it's because of advances in our understanding the anatomy and the physiology, as well as advances in computer technology, navigation, anesthesia techniques, and instrumentation that we can operate safely here. We tried treating brainstem and deep cavernous malformations with radiosurgery in the late 1980s and early 90s, and it doesn't work. And so in 1990, I started operating on cavernous malformations in these deep locations, and I've operated on 316 patients. And as we learn more about skull-based approaches, we've applied these in various ways to operating in the brainstem and thalamus. Here was one of the first patients I treated, and the youngest. You can see he bled into his medulla and lower pons from this cavernous malformation. And there are safe places to enter the brainstem. We've learned this is the lateral medullary zone, which is how I entered this. This is on the left side, a far lateral approach. The feet are down here, the head's up here. And here are the lower cranial nerves. I'm pulling the vertebral artery medially and stimulating the side of the medulla. This is the safe zone. Make a small incision. And there's the clot you'll see being expressed. And then fairly straightforward manner, able to get out the small cavernous malformation. And what surprises me even now is the way the brainstem can reconstitute itself after resecting these malformations and taking out a clot. And he was one of the minority of patients who actually improved immediately, probably by removing the clot as well as the malformation. You can see his hemiparesis resolved immediately, although he still has a 6-nerve palsy. This was the first patient that I attempted to resect a malformation after he had 3 clinical hemorrhages, where the malformation did not present to the peel or ependymal surface. And the way I approached this was a subtemporal approach with a transitorial extension that allows you to reach the upper pons. And I'll show you another case where I actually did a petrosectomy in order to reach more anteriorly in the pons. Navigation is critical. This is how I approached it. This is the right subtemporal approach, the carotid arteries anteriorly here. And what I'm doing is to retracting the tentorium. I cut the tent. Here's the 4th nerve, the 5th nerve, the superior cerebellar artery. After stimulating the side of the pons, made a small incision. Here's the hemosiderin stained brainstem, taking out the malformation, and was able to do this through a 3 or 4 millimeter opening. We did lose his motor evoked potentials, and he woke up hemiplegic. I was quite worried, although within 12 hours, he was moving the left side quite well. And you have to understand, you will set patients back temporarily. However, within a week, he only had mild left ankle weakness. So within 4 months, he was neurologically normal and shooting his single-digit handicap in golf again. Now, this one malformation in a patient who had bled 3 times over 4 years is located more anteriorly. And here, what you need to do is a petrosectomy, so drilling the petrous bone extradurally, opening very anteriorly. Now we're working actually anterior to the 5th nerve. And again, making a small incision in the hemosiderin stained pons and then taking out the malformation. And she did quite well. For these anterior midbrain lesions, I find them quite challenging. And what I've been doing is to actually approach it contralaterally instead of ipsilaterally with retraction of the ipsilateral peduncle. So come in from the contralateral side that gives you the best angle. And the key here is to be very cautious working around the basilar artery and all the perforators. And you can see here, this is on the right side to take out the left-sided lesion. Here's the basilar artery exposed. the malformation, and taking out the malformation worked very nicely for this patient. What about the thalamus and upper midbrain? For these lesions, I like to approach it, if it doesn't come to the surface, to the pulvinar. I've never seen a deficit operating there. And the key to this are the veins, of course. And you must be very, very meticulous in preserving the deep venous system. So for this case, I came to the paramedian with the patient prone. So the feet are down here, the head's up here. This is the falx tentoriums here, and incising the inferior falx and the tentorial edge. Here's the pulvinar, and again using navigation to go directly to the malformation and take it out. We worsened his diplopia slightly, but however that recovered. What I think is a major innovation is what I've been doing for the past decade or more, or a little more, and that's using a CO2 laser, which has a diameter of 0.5 millimeters. And I've used this in 231 cases, mostly CAV-MALs, since 2009. And I'll show you how this works. I think this is absolutely the gentlest way to take out these deep vascular malformations, or those in critical areas. Here's a dorsal midbrain lesion, and using a far lateral infratentorial supracerebellar approach, you can see the laser, 0.5 millimeter, make a small incision. And this is nice because you can use it as a dissecting instrument. It also seals and severs the small vessels. It does not interfere with electrophysiological monitoring, unlike the bipolar, and it does not require tugging of tissue. Another case I used this on, difficult lesion again in the anterior midbrain and hypothalamic region. And the way I approached this was actually through the lamina terminalis. It was the first time I've done this approach. Here you can see we're on the left side, the lesion's on the right, so contralateral, optic nerve. Here's the carotid artery. We came over here in the lamina terminalis. Now we're working in front of the optic chiasm, opening the lamina terminalis. And there's the malformation with just a small rim of tissue. You have to be careful of the mammillary bodies and the fornices here. I don't think I could have resected this using even the smallest bipolars because of the small working space, but the laser worked beautifully to resect this malformation through the lamina terminalis. And she did well. Within 6 months, she was back to normal, actually, back to work. And what we found pathologically is that as opposed to the bipolar, where there's significant thermal injury, there's minimal injury using the laser at very low wattage of 5 watts. So I talked about the advantages. The main disadvantage are hemostasis for larger vessels where you still need to use a bipolar, and you cannot operate around corners since it's a fixed non-malleable laser. And you can see, if you look at the immediate results post-op, a third of the patients are worse. However, if you look at 6 months, and you have to explain this to the patients and families, 90% of the patients are the same or better. I want to talk about another innovation that we've been pioneering at Stanford, and that is neurosurgical simulation using 3D virtual reality. Very useful for preoperative planning, intraoperative navigation and use, patient engagement, and especially education. We've done about 1,500 cases since 2016 at Stanford. Here's an example of a giant aneurysm that came in. It was a ruptured aneurysm in a young man. And you can see the anatomy with the conventional 3D reconstruction. Difficult to see exactly what's going on, but look at this. You can actually rehearse the surgery ahead of time. You can see the detailed anatomy, and you can see the M1 going into the aneurysm. You can delineate the 2 branches, M2 branches coming out of the aneurysm. You can even make a 3D model a print of this. And this helped me to decide to actually do a bypass and trap the aneurysm, which worked nicely for this patient. Another patient with polycystic kidney disease and a complex middle cerebral artery aneurysm. We couldn't even do an aneurysm, an angiogram because of her renal failure. And so again, look at the beautiful anatomy. We weren't sure based on the conventional imaging if this vessel was coming out of the aneurysm, but this 3D reconstruction on surgical theater is the system we're using, showed that it was likely a vessel that was adherent to the aneurysm dome and not arising from it. And that's exactly what it looked like at surgery. Here's the middle cerebral artery. Here's the vessel I had to dissect off of the aneurysm. And then once that's dissected off, again, a fairly straightforward manner to simply clip the aneurysm and reconstruct the bifurcation, preserving all of the vessels, confirmed with Doppler, and then with an intraoperative ICG angiogram. And she did well, went on to get her kidney transplant. For AVMs also, this 3D virtual anatomy has been really a quantum leap in understanding the anatomy of the AVM with respect to the brain, but also being to overlay the fiber tracts, the cortical spinal tract and the sensory tract, as well as the visual fibers to help select what the best approach to minimize injury is. Very, very useful in terms of approaching brainstem cavernous malformations and other deep lesions. And we can now even overlay functional MR data onto the 3D imaging, which again, very, very helpful in terms of operating on these patients. I want to show you how we use augmented reality. This patient had a subarachnoid hemorrhage from this complex middle cerebral aneurysm, was partially coiled elsewhere and then transferred to Stanford with residual aneurysm. And here I'm dissecting the aneurysm. It's a mess because of the subarachnoid hemorrhage. And here's the middle cerebral artery, the distal M1. And I had a hard time knowing where the temporal M2 branch was because of the blood and the aneurysm dome. And here we can overlay the image preoperatively to find the temporal branch and avoid rupture of the aneurysm. So very, very nice way. And here you can see the coils to use this augmented reality and help define the anatomy, which is obscured by clot and subarachnoid hemorrhage with a nice postoperative result. I'll show you another example. This was a, this was a very complex paraclinoid aneurysm that Arte described so well. And you can see, I'm going to show you the 3D rendition of this. What we're able to do is actually rehearse the surgery through a craniotomy, and then we can see the three-dimensional details of this aneurysm with respect to the clinoid. And then furthermore, at surgery, I'll show you how we use the augmented reality. So here I'm drilling the clinoid. And so the clinoid's off, here's the aneurysm, but now I overlay the augmented reality to see exactly where the aneurysm, to see if I have enough exposure after opening the dural ring using a fenestrated clip, right angle clip. And then ICG nicely shows it's patent. There's the aneurysm dome, which has been clipped. And then again, the augmented reality confirms that I've got the whole aneurysm clipped, and you can see that true here. Here's the clip with a nice result. These giant aneurysms, I think, are still very, very challenging, even with endovascular therapy. Here's a patient I treated recently with a two giant tandem left vertebral artery aneurysms arising from the left vertebral artery. The more proximal aneurysm is mostly thrombosed with a channel through it that fills the distal giant aneurysm here, and there's also some inflow you can see from the contralateral vertebral artery retrograde through the ipsilateral vert into the aneurysm. So we coiled this giant aneurysm and occluded the left vertebral artery. Patient did well for a year and a half and then progressed with progressive brainstem compression signs. You can see there's still a jet of blood from the contralateral injection retrograde through the distal vert on the ipsilateral side. And here's the pica on the left draped over the aneurysm. You can see the fiber tracts, corticospinal and sensory tracts are distorted and compressed to the contralateral side. So what I did here was to use a left retromastoid approach, retract the cerebellum. Here's the lower cranial nerves. Here's the 12th nerve. Here's the lower aneurysm, which was largely thrombosed, but causing mass effect. I couldn't cut into it, so I had to drill off the calcified rim carefully and then use a CUSA or Sonopet to remove the clot and decompress the brainstem. The distal aneurysm was still patent, even though it had coils in it. Open it up, there's still some bleeding retrograde from the other vert. And you have to be careful with these coils, they're very sharp. Cut the coils, remove clot. And here you can see actually the distal vertebral artery coming out of the aneurysm with a perforator. Oh, sorry about that. Let me show you. Okay, so now I have trapped the aneurysm, you can see. And then I went on to clip the remaining aneurysm actually to seal the final dome. This patient had mild worsening of his symptoms, but within 9 months, most of his symptoms had resolved completely. We've now clipped 95 aneurysms after coily stenting or flow diverter, and I still think that these giant aneurysms will have to be treated through a combination of techniques that are going to require surgery. I just want to end by talking about something that is completely different, but I think an innovation that we all are going to be applying within the next decade, and that is a strategy to recover function after stroke, for which we have no treatment now, and one of those is cell transplantation. We started this 20 years ago in my lab, transplanting human fetal neuronal stem cells into the rat brain and showed you can recover function. And of course, the original notion was that these neural stem cells transplanted become cells in the brain and then differentiate and reconstitute circuits, but that's not true. What they do is to secrete very powerful trophic and growth factors that enhance native mechanisms of recovery, including axonal dendritic sprouting, angiogenesis. They have a very powerful effect on neuromodulation, on immunomodulation. So in a simple sense, what they do is turn the adult brain into a neonatal or infant brain, which recovers very well after insults like strokes. We worked with a local stem cell company and did the first intracerebral stem cell trial in North America, taking donor cells from 2 donors that were expanded in culture, cryopreserved and shipped to the sites. And we treated 18 patients who were between 33 and 75 years old. And between 7 months and 3 years after their stroke, you knew they weren't going to recover. We looked at efficacy and safety, and this is what the strokes looked like. They had to have a subcortical stroke, which is what we targeted, but many had a cortical stroke as well. We did it under local anesthesia using a stereotactic frame and a burr hole the size of about a nickel. And we treated 18 patients. I treated 12 at Stanford, 6 at University of Pittsburgh. Were treated, and we did a dose escalation. And not only did we find they were safe, but to our surprise, we found that the patients recovered their function starting within a month, increased to 3 months. We had a statistically significant improvement in their baseline chronic deficits at 6 months. This was compared to their baseline motor dysfunction. And this was true on several of the scales. I'll show you a patient. This patient is 2 years out from a stroke. She's paralyzed on the left side, cannot move her arm or leg except for her thumb. This is a neurologist, Neil Schwartz, examining her. Can't get her leg off the bed. She's in wheelchair for 2 years. And we transplanted her and went by the next day to see what she was like. And here she is 1 day later.
Do you know? Oh my goodness.
Video do that.
Touch my hand. 1, 2, 3, 4, 5.
So this really surprised us. In fact, Neil Schwartz, the neurologist, sent me this. I must admit, it's a bit of a miracle. When a neurologist says that, you know it's not a placebo effect. We tried to figure out what was responsible for the restoration of function, and there's no change in the fiber tracts, but we noticed 1 week later a new flare lesion, DWI negative, so it's not a stroke in the premotor cortex. It goes away by 2 months, never reappears, but she's better even a year later. And now she's walking. A second patient, a younger one who had a stroke 2 years out. She cannot move her arm. She could barely talk. You couldn't understand her, and she could not walk well. She did not want to get married because she felt she'd be embarrassed walking down the aisle. Here she is 2.5 months after her transplant. And then here she is 4.5 years later, and she's still this good 7 years later. She actually gave me an award at the Smithsonian Institute.
For 2 years after that, I was unable to say more than 20 words. I couldn't move my right arm more than a few inches and could only walk for 5 minutes without needing a wheelchair. It's been 4.5 years to the day now, and I'm able to climb stairs, have conversations with family and friends. I run, I work out. My life is amazing. I was also able to become a mother.
So look at her scan. This is pre-transplant. This is a higher level. 1 day later, the higher level looks the same except for a little blood in the sulcus. At 1 week, you can see she's got that flare lesion in the premotor cortex. It resolves again. By 2 months, never reappears, and 14 of the 18 patients had this new flare lesion. That lesion, which is only transient, is significantly correlated, the size of that, with the recovery at 12 months and 24 months. So what do we learn? Not only is this safe and feasible, but we learned something we didn't know. It's changed our notion of what happens after a stroke. Those circuits are not dead or irreversibly damaged like we thought. They're probably idling, and we can resurrect them. We're just figuring out how. The company and I've been involved in doing a chronic TBI multi-center study with the same cells, which was positive. We did a further study with stroke patients, which was unfortunately negative at the primary outcome, but subgroups were positive. So we're looking at which groups improved. We still don't know what the best cells are. A lot of unanswered questions. When should we treat the patient? Should we immunosuppress? We didn't immunosuppress in that trial. How should we deliver the cells? I think intracerebral into the brain is going to be best, and that's what we as cerebrovascular surgeons are going to be doing. So I think that this is a therapy that's going to hold great promise. We still need to answer fundamental issues, and we need to do further phase 1, 2, and 3 trials with controls. So with that, I want to thank you all so very much for your attention. Again, I've really enjoyed the symposium, and I hope you'll enjoy the remaining days of it. Thanks a lot.
Thank you, Gary. That was very inspiring. And I think it's a phenomenal way of finishing the day today. I want to thank all the attendees, between 400 and 500 during the day. I also want to thank, of course, all the faculty. You've been all great. Thank you so much for staying with us. Tomorrow we have a long day with 4 different sessions, starting with the skull base, then the Evandro de Oliveira special session followed by bypass surgery and then white matter and complex brain surgery. So I hope to see you all tomorrow. Professor Kobayashi, do you want to have a few words to end the day? You're muted.
Shige, you're muted.
Shige, we cannot hear you.
We can't hear you, Shige.
Can you hear me?
There you go.
Yes.
Yeah, Gary, nice to see you. Many years. Yeah. It's been a great day, Joan. Thank you very much. It's a wonderful program.
Thank you very much. Well, some of us were going to sleep. Some of you enjoy the rest of the day, and we'll see you tomorrow.
Thanks a lot.
Okay, see
Great
you.
program.
Thank you, guys.